Great. Yeah. Hello everybody, and a warm welcome to Pan Ophthalmologica 2025 and global webinar organized by Arunodaya Desert Eye Hospital in celebration of World Sight Day. So we are now in Hall A, where we have an esteemed panel of speakers and dynamic moderators and panelists for this inspiring scientific journey. So without further ado, let's begin with our first speaker, a true legend, Dr. Steve Charles, who's a pioneering vitreoretinal surgeon, engineer, innovator, inventor, and he also a licensed airline pilot too. And he has performed more than 38,000 vitreoretinal surgeries, authored more than 170 papers, and with over 100 patents. And he's also the architect. He's also the architect behind Alcon's Constellation Vitrectomy System, a technology most of us rely on today. So over to you, Dr. Charles, and he'll be talking to us on advanced fluidics.
Thank you so much. I apologize for one, not being there in person, and two, for not being able to continue past my talk to participate in this fantastic panel that you've assembled. This is my surgery day, and surgery starts in 45 minutes here, so I'm going to get on with it. As disclosed, I've worked for Alcon for 34 years. I did get a royalty on the Constellation system. I do not on the new system called Unity, and I'm going to describe the fluidics of Unity, and I'm the inventor of the fluidics of Unity, but I do not have a royalty on that system. So it's not at my economic benefit to talk about it. We've already said that. So control systems, be they the throttle on your automobile or the brakes on your automobile or steering, or I fly jets, and whether it's the throttles, ailerons, elevator speed, brakes, slats, all of that response time is absolutely critical in these real-time systems. Some people call them, the National Science Foundation calls them high consequence computing. The cataract and vitreoretinal surgeons need incredibly rapid response time, particularly to the foot pedal commands for flow or vacuum, as well as commands on the user interface for infusion flow, infusion pressure, and by default, interocular pressure. Air is bad in any control system. That's why pneumatics are not used for precise control. They're used more for open and close the gripper on a robot that picks stuff up, but not precise control about how much force is applied. Because air is compressible, it slows the response time. And we've historically had air over fluid infusion systems. The so-called gas force infusion, invented gas force infusion, and we've had air over fluid aspiration systems for the past 4 generations of machines. As I was involved in developing Accutome 8000, which had linear suction, then the Ackerson, the Constellation, and now the Unity, and in all cases, except Unity, we had air over fluid on both the infusion side and the aspiration side, which, as I pointed out, slows response times. So how did infusion systems evolve? Initially, it was all gravity feed, bottle height. That doesn't imply air in the system, but it does slow the response time because of the inertia and the fluidic resistance of the fluid flowing down the tubing from the bottle. The Centurion phaco machine from Alcon had bag squeezing, which does work, but the bag is elastic, somewhat like air over fluid in infusion systems, as you see. So if you go down the right side of this slide, I already mentioned gas force infusion, invented gas force infusion. So on the Constellation, we used dual infusion chambers that were very small to decrease the amount of air, the volume of air over fluid on the infusion system. And it infused with one chamber, and then, well, the other chamber was filling, and it alternated between the 2 infusion chambers. So that sped up the response time, expedited the response time, made it close to the real time, but it still wasn't where I wanted it to be. So now on Unity, we have roller pumps. It is a mistake to call this a peristaltic pump system. Peristalsis is pulsatile. It makes perfect sense to have a peristaltic pump that's pulsatile, like diastole and systole for ECMO, for a heart-lung machine for cardiac surgery, or for dialysis, because that's what your blood pressure does. but pulsations make absolutely no sense to infuse into the eye or to aspirate from the eye. So instead of this saying, oh, is it a Venturi or a peristaltic pump? Wrong argument, has nothing to do with what we're talking about. So it's a displacement pump on the infusion side on Unity, and it has a very fast microstepper motor. But trick to it is there's a decoder on the motor, and that has 1024 counts. So what does that mean? Since it's a displacement pump with no air over fluid, it knows exactly what the flow rate is in real time. It knows at what rate you're pumping fluid into the eye. So, and that might be going to a wound leak, or it might be, of course, going to the aspiration system, or it might be overpressurizing the eye, for example. We'll come back to the pressure in a minute. But in short, there's no pulsation. Why? It's a dual arc or dual segment pump with an odd number of rollers. So the two segments are 180 degrees out of phase. So yes, it's kind of like a peristaltic pump, but unlike peristaltic pumps, there's no pulsation. And that's an Alcon invention that really is quite effective. So this shows you the two chambers we had on Constellation. So it would infuse with one while it was filling the other one. And you can see there was a modest amount of air in this pressurized airspace overlying the infusion fluid. But nevertheless, compressible air is what we want to eliminate in this new system. So now let's talk about aspiration. It's mind-boggling to remember that Macomber, along with the late John Murray Perel, invented vitrectomy, although it had been done earlier in Japan, but never got popularized or commercialized. Think about it, that he had the assistant run a syringe. That's like you're steering your car and somebody else is running the gas pedal, with your verbal command or trying to guess what you want. So then Connor O'Malley, who doesn't get near enough credit, invented with Ralph Hinz and engineered the Accutome 800, which had a very large air over fluid infusion chamber, but it was foot pedal controlled by the surgeon, not controlled by the assistant. So a huge step forward. I then worked with Berkeley Bioengineering and later CooperVision that developed the original Accutome when it was Berkeley, and invented linear foot pedal control. So that's on every phaco and vitrectomy machine in the world. So I patented linear control. But we had quite a large chamber that had to be manually emptied. So a lot of air over fluid. So then on the Acurus, we continued with air over fluid, but it was automatic emptying of the infusion chamber so we could make it smaller and not have to hold a tremendous amount of fluid in that space. So therefore, we reduced the volume. On the Acurus, we had much smaller aspiration chambers, and three proportional valves, a so-called boost valve, a valve to let air in, as well as two proportional valves to control the vacuum, the boost valve and the regular valve. What was that for? To have a significant dynamic range. So it would work at 30 millimeters of mercury when you're trying to trim the flap off a flap chair or horseshoe chair, but it would also work when you needed 650 millimeters vacuum to get dense lens material out of the vitreous cavity with the fragmenter, or heaven forbid, with the cutter. So now the Unity system is different. It has the displacement pump, 7-roller, no air over fluid, as I keep saying. And it has an encoder, which I also pointed out, the point of which is to have flow sensing. So this shows you graphically first a rather large chamber on the Accutome 800 in the upper left-hand corner, then the Accutome 8000 in the upper right-hand corner, and then the MVS from Midlabs, which I invented, which has a smaller chamber. So we progressed from foot pedal control to linear foot pedal control, and then decreased the amount of air over fluid as we progressed. And then the Acurs continued to have air over fluid aspiration. And it had air over fluid infusion as well. And then we progressed to the Constellation, which I've described. It's a very complicated slide, and I apologize for that, but this is the so-called FMS, which is the cassette on the Unity system. So it has both two pumps that are these non-pulsatile displacement pumps, one for infusion or irrigation, which is the bottom pump, and you can see the dual arcs that offset each other at 180 degrees, so it's non-pulsatile. And then in the upper pump is for aspiration. So now we have a displacement pump. So once again, this isn't about peristaltic because it's non-pulsatile. But in the middle of both of these pumps is an eddy current pressure sensor that's extremely sensitive, plus or minus 0.1 millimeter of mercury in real time. So now we know the flow rate on infusion, the flow rate and aspiration, and the infusion pressure and the aspiration pressure in real time. Four critical parameters. One more thing made this fast. If you look at the vent valve in the lower left-hand corner of the cassette where it says vent valve, that has a very high-speed motor. There's no more tubing compression valves. Those are like when you measure blood pressure, either it's flowing or it's not. They're not proportional. So it's a proportional valve. That means that you send a command to it and you control how much venting there is. And it has a very fast motor. So these are rotary valves, not tubing compression valves, and very fast. So now we've got truly real-time control over infusion flow rate, infusion pressure, aspiration rate, aspiration or vacuum on the aspiration circuit, and we have venting. So if we say there's too much vacuum, we want less. So what's the goal? The goal to make the rate limiting be the doctor's reaction time. That's already 400 milliseconds. Why add 200, 300, 400 milliseconds or even longer like other machines in the marketplace have had forever and still have? Let's not add to it. So let's be down in tens of milliseconds in terms of response time at the system level. And why does that matter? Why are we moving to rapid response time flow control? Vitreous, as the boldface print here points out, is very anisotropic. So there's so-called pockets of liquid vitreous, a collagen fiber matrix, dense gel, part that's already been liquefied by the infusion fluid, other parts that are mostly just BSS if you're halfway through the core vitrectomy. So since it has this incredible dynamic range of fluidic resistance from the actual material you're removing, why not use flow control so that instead of having the flow go all over the place in response to a vacuum controller where let's be able to control it. So what does that give us? It's really significant in vitrectomy because when the retina is detached, it's just immobile. You can trim the flap off a tear, trim the vitreous off the flap, trim the edge of a giant break that got a little PBR, and with not a concern that you're going to gobble up the retina and cause iatrogenic retina breaks. Hard to prove in clinical trials, but it should be, and in my belief, there already is. I've been using the Unity for 14 months now, full time, after working on it in the lab for many, many years. A much reduced rate of iatrogenic retinal breaks, just better control. So where do we use peristaltic? Where do we use a Venturi pump, which is a vacuum controller like we had on all the prior machines? Only if there's air in the eye. So as soon as you switch to air in the eye during fluid air exchange, then vacuum control instead of flow control is the right thing to do. There's a term in military called software-defined radio, and I've been interested in electrical engineering and mechanical engineering. I've been working on this a long time. And so I coined the term software-defined fluidics. Once you have super fast response time, vacuum and flow rate on the aspiration circuit, pressure and flow rate on the infusion circuit, now the software defines the behavior instead of the pump defining the behavior. The pump is not rate limiting. And you can't run this all through one processor that supports the screen. So now there's 29 embedded processors, 4.3 million lines of code in the Unity VCS. And this term software-defined radio came about because in the US there were Marine Corps, Air Force, Navy, Army radios could talk to each other. And they said, so instead of having the hardware define it, let's have broadband linear amplifiers on RF on both on the antenna from receiving and antennas for transmitting. And then let's be able to, in software, say, be a UHF radio, be a VHF radio, be an Army radio, an Air Force radio. And that allowed interoperability, but it allowed you to define the behavior of the radio, not in the analog electronic components, but in software. Now that term has been adopted by the Society of Automotive Engineers, and they call it the software-defined vehicle. Now that you have super rapid internet networking in your vehicle and microprocessors all over the place to steer the rear view mirror, to run air conditioning, to run braking, throttle, cam timing, fuel injectors, ignition timing, all of that is now under software control. So you can change the behavior of the car, not by let's use a different motor, a different pump, or a different valve on the next one. Let's change the code. Now that you have fast response time, distributed processing with time-sensitive networking. I mentioned this already. Vacuum control. I do a lot of vitrectomy under ear. When would you do that? You've thought you removed the vitreous. The retina's rather mobile, retinal detachment case. You trimmed the vitreous off the flap tears. You're now doing fluid ear exchange and endodrainage of subretinal fluid. And you notice, oh, there's still some vitreous there. That's the time when you want to do vitrectomy under air, and you want to use vacuum control instead of flow control for that. So it still has a place. So every time I switch to fluid air exchange, whether it's the cutter in the eye or a soft tip cannula or a backflush cannula, I switch back to vacuum control because there's already air in the system, and now we want to be able to control the force that's applied rather than the flow rate. I mentioned this already. I think in the interest of time, we'll cut this off. And my final slide that I want to talk about, it's on the product, the Unity VCS machine. It by default is not initiated, and Alcon's getting some feedback from a variety of experienced surgeons around the world about how to signify this. But the current method, because it senses flow rate and it senses vacuum on the aspiration side of the circuit, you can calculate the fluidic resistance in real time. And they've developed an algorithm back to a software-defined fluidics that says, oh, you're in vitreous now. No, you're in BSS. As all of us who train fellows know, they can spend 30 minutes removing BSS because they haven't even engaged the port in the vitreous. And that's a commonplace problem when you're learning. So to do rather complete core vitrectomy, now there's a sound display. So you hear sort of a thunking sound, boom, 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 like that every time you're in vitreous. So so instead of using stupid terms which are meaningless like flow efficiency, efficiency is, are you removing BSS or are you removing vitreous? And so this tells you you're in vitreous. And it's called, it has a variety of terms. I call it fluidic resistance detection and then display in this auditory thing. Well, that's all I wanted to present. I hope that was helpful. And again, I apologize for having to drive off to the operating room and not be able to participate in the panel discussion. But I guess we have time for a question or two. Is that correct?
Yes, sir. Couple of questions. Thank you, Dr. Charles. That's a great presentation. So just a couple of questions. One is, so in an ideal case with the Unity, what would be your settings for a core vitrectomy and for a base shaving with the new Unity?
I always the flow rate could go up to 10 cc's per minute. Would you use that? Probably not. So I emphasize to the fellows and to everybody I teach, use the dynamic range of the foot pedal. We've done a lot of work to make the foot pedal have a dynamic range from infinitesimally low flow rates when you're trimming the edge of a giant brake that has a little PBR, or trimming the flap off a horseshoe chair, to higher flow rates if you're trying to get blood out of the eye or remove lens material that's dislocated to the back of the eye. And so I emphasize pedal control of that instead of push the pedal all the way down and then control it by the maximum setting in the console. But I would have it top out at 8 or 10 cc's a minute, but I would only be at that level in a dense vitreous hemorrhage or dense lens material on the back of the eye.
Okay, great.
And I use higher infusion pressures than most people do. I use 45. I don't think it's as necessary with this new system as it used to be, because we would quite frequently, particularly with 27 gauge infusion and a vitreous cutter, or worse yet, a fragmenter removing the fluid, you could get a soft eye. So we don't have that problem like we used to. I haven't seen a soft eye even for 1 minute, one time, and I've done several 500 plus cases with Unity.
Okay. And so your experience with the 27 gauge with the Unity, if you have ever tried, especially
It's
how's
been
the
very
flow
good.
and
It has a dynamic stiffener, so that you don't have tool flex as a problem on the endo illuminator on the cutter. That helps. But the flow rate is excellent, and they've redone the infusion, excuse me, the entry systems, so that it's even easy to put 1,000 centistokes oil or to remove 1,000 centistokes oil. I never use 5,000. There's no advantage to 5,000. It doesn't change the emulsification rates, contrary to popular belief. And so I'm a 1,000 centistoke guy, and it's very fast to put the oil in and take it out, which was the only limiting thing. Now, of course, there's not a 27 gauge fragmenter. So particularly if you're teaching residents, you're going to see dislocated lens material in the back of the eye. Or in the case in India with these hard cataracts, 4+ nuclear sclerosis, you're going to see some in the back of the eye. The fragmenter now has ozzel, which is fantastic. Torsional phaco. It's extraordinary, and flow control is ideal for that. That said, it's not, instead of 20 gauge, now it's 22 gauge.
22
So
gauge.
it's a smaller diameter. One little 80 vicryl will close the wound. But the fragmenter, when you're dealing with residents dropping lens material in tough cases, you got to be ready to put that fragmenter in, and it works really well with this flow control. There's no occlusion break with the flow
Right.
control.
Oh, great. Okay. So anybody else, any questions? One final question for Dr. Charles before he goes.
Well, thank you again. I wish you
Yeah.
best,
Thank you.
all the best for this meeting.
Yeah. Thank
Thank
you.
you so
Thank you
much.
so much, sir. Thank you for your presentation.
Take care now.
So, yeah, thank you. So now I'll hand over to Dr. Eche, and she'll introduce Dr. Barbara while I load her presentation. Dr. Barbara won't be here for some time till her presentation goes, but then afterwards, I think she'll be there for the panel discussion. Over to you, Dr. Eche.
Thank you very much, Dr. Shishir. And hello, everyone. I'm really honored to introduce Dr. Barbara Parolini as our next speaker. Dr. Parolini is a distinguished vitreoretinal surgeon from Italy with more than 15,000 surgeries and over 100 peer-reviewed publications. She has performed numerous live surgeries and has been an active tutor at vitreoretinal schools around the world. She currently serves as the vice president of the EVRS and is a board member of the Retina World Congress. She is globally recognized for her expertise in high myopia, macular traction, and complex PVR cases, as well as for being the inventor of a modern macular buckle. And above all, she's an inspiring mentor to young surgeons worldwide. I'm now passing back to Dr. Shishir to play Dr. Parolini's talk on the break patching technique to prevent PVR, and then we are going to welcome Dr. Parolini for discussion.
Sure.
Dear colleagues, I'm happy to present you what I hope you will find to be a potentially good idea to fill some unmet needs. A retina detachment due to retina breaks present on areas of atrophic choroid is at high risk of anatomical failure. We know that research indicates that the technique of patching or stuffing a macular hole or an optic pit is effective in addressing the related retina detachment. And various materials have been suggested for this purpose, including internal limiting membrane, human amniotic membrane, tenon, and fibrin glue. This study aimed to assess the effectiveness of patching retina breaks positioned on atrophic choroid, and a 12-month follow-up was conducted to evaluate the outcomes. Data were collected from 12 eyes with retina detachment and breaks on choroidal atrophic area, Retinal attachment was achieved using fluid exchange or perfluorocarbon liquid, and bovine pericardium, known as tutor patch, was used to seal the retinal breaks. Silicone oil was used as tamponade in all the patients, and the patients were monitored for up to 12 months after surgery. So this is the first case with which I started this new idea. He was a 60-year-old Caucasian male with decreased visual acuity of light perception in one eye, with high myopia, almost minus 20 degrees of myopia, with a total retinal detachment and vitreous opacities. So as you will see in the video, I first removed the dense vitreous opacities, and then I discovered that the patient not only had a macular hole, but a series of holes on the nasal side of the papilla. And when I completed the fluid exchange, I realized that in that area, it looked white. There was no choroid at all. So I was wondering how I could deal with those holes being into the staphyloma and into the atrophic areas. I dealt with the macular hole through the use of a macular buckle, and but I was wondering how to treat the nasal holes. So I decided to apply the idea of covering the holes using a tutor patch placed under silicone oil to cover the whole atrophic area. In the wide field OCT, you can appreciate how deep was the staphyloma surrounding the papilla. On the left, you see the macula on top of the slope, and on your right, you see the area where the series of atrophic breaks were. So in this slide, you see the outcome 12 months after surgery and 6 months after silicone oil removal and phaco. The patient vision is now 0.4 decimal, and he has a myopia of minus 2.50. The retina is completely attached, and you can see the white patch on the nasal side of the papilla remaining stable and not covered by membrane. So these are other cases in which I have applied the same technique. So my first conclusion is that rheumatogenic retinal detachment in highly myopic patients represent a challenging topic, especially if associated with retina breaks in area of choroidal atrophy. And given the irregular anatomy of the eye in high myopia, these lesions are sometimes only detectable intraoperatively. The idea of patching the retina breaks on atrophic areas might guarantee a higher anatomical success rate. And to my knowledge, this is the first case described with the use of bovine pericardium to close the break. I submitted this case series for publication, and I just got the review, and hopefully it will be soon published. So I don't think it is about bovine pericardium. I think it is about the idea of patching the breaks. Other materials could be used, but human amniotic membrane might not be available easily in every operating room. Retina patches imply creating more holes, and this would be risky. And internal limiting membrane is not easy to remove in high myopia, plus you don't have a huge amount of ILM to cover multiple breaks. Fibrin glue is a good alternative, but it is only temporary. And Tenon could be a good alternative too, although I think it's not as easy to handle and not so suitable to cover large areas. But so once I saw that the tutor patch was working very well in high myopic eyes, I decided to translate the idea of patching the breaks to prevent PVR. PVR is a wound healing process, and it is mainly due to the transformation of RPE cells into fibroblasts, which migrate onto the retina surface, creating membranes. At the moment, we have different options to try and limit PVR: methotrexate, mitomycin C, chorioretinectomy, especially after trauma. But unfortunately, none of them have demonstrated a strong effect, or they are still under study. So this particular study aimed to assess the effectiveness of patching retina breaks in cases at high risk of developing PDR. For example, retinal detachment with large breaks and extensive exposure of RPE and trauma cases. This is an example in a 55 Caucasian male with retinal detachment due to a giant tear. So you see at the end of surgery, I still have a wide area of exposed choroid. So this means high risk of PDR formation. I decided to apply the same idea that you have seen in the previous video, and I have inserted a large tutor patch that I inserted through a secondary sclerotomy. And this is how the patch looks over the exposed choroid. So I implant the tutor patch under silicone oil because it is much easier. This is how it looks a few months later. He didn't develop PDR. This is another case report, a 47-year-old male that was already operated multiple times and still he had an inferior detachment. I decided to cover the exposed choroid, and this is how it looks 12 months after patching the exposed choroid with no PVR, and I actually just removed the silicone oil. This is a case of trauma secondary to gunshot. So you can imagine this case was at very high risk of PVR. Here you see the fundus with the big area of exposed choroid due to the impact with the foreign body. It was covered completely. Another case that received 5 surgeries for retinal detachment. He comes to me still with the detachment and multiple areas of exposed choroid. One even at the posterior pole of the nasal side, as you can see from the wide field imaging. So here you see the postoperative results. I have covered basically all the exposed areas with the tutor patch. And this is how the patient looks 6 months after surgery with no signs of PVR. So my conclusions are that preliminary results are promising and show that patching large retina breaks does not damage the retina, and we might prevent exposure of RPE to the vitreous cavity and potentially prevent PVR. I hope you will like the idea and you will try yourself. And with this, I invite you all to come to the next EDRS meeting, which will be held in Cancun in November from 12 to 15. Thank you.
Yeah, I think Dr. Barbara has not yet joined us. So I think we can move on to Dr. Maria Berrocal. Once Dr. Barbara joins us, then we can open the panel for discussion. So over to Dr. Rohit, who will introduce Dr. Maria, and then she can ready her presentation.
Yeah. Hello, everyone. I am Dr. Rohit Agrawal. It's an honor to be present at this meeting. I am inviting Dr. Maria Berrocal for this talk. She's a world-renowned vitreoretina surgeon from Puerto Rico. She's recognized for her work in pioneering advanced retinal techniques and among the first few who adopted 27-gauge vitrectomy and 3D visualization system. She is a sought-after international speaker and educator. She is a medical director at Berrocal Institute and actively involved in global ophthalmic education and clinical innovation. So over to you, Dr. Maria. Welcome to the conference.
Thank you so much. It is an honor for me to participate here in the Retina Vision Day. So thank you so much for having me. I'm going to talk to you about vitrectomy techniques in diabetic retinopathy. These are my financial disclosures. So diabetic retinopathy is really the modern plague. There are almost 500 million diabetics in the world. It's expected to reach 17% of the US population. The prevalence is 20% in people over 65 years old. And by 2050, it's expected that there'll be 1.3 billion persons with diabetes. And it is really the leading cause of blindness among working adults. Indications for surgery are usually vitreous hemorrhage, traction retinal detachment, traction and rhegmatogenous detachments, macular edema, severe PBR with an attached hyaloid. But the principles are really pretty much the same. We have to remove anteroposterior traction, do membrane delamination by manual illuminated picks and forceps can work, and then block delamination. Okay, sorry. But the techniques have evolved. There's been a trend towards smaller gauge surgery. We have better vitrectomy machines, better controls, improved visualization systems, 3D systems, wide angle viewing systems. We have pharmacological adjuvants. But still, the main thing in all these cases is that we have to remove the hyaloid because the hyaloid is the enemy in diabetes. My preferred techniques for this are using the smallest gauge for the most difficult cases. Smaller gauges allow us to do very specific techniques and get into very small planes. We can do the lift and shave dissection, which I described, blunt dissection, back cutting, membrane peelings with the vitrectomy probe, do inside out dissection, which I like. I can use, sometimes I use PFO, visco dissection, anti-VEGFs, and different techniques to achieve hemostasis. So I'll just show you a few things. So this is a diabetic patient, and here you can see how it bled because of fibrovascular formation, and I'm lifting the hyaloid. I am detaching the hyaloid so that all the fibrovascular tissue does not have a scaffold to keep growing. If we remove the hyaloid, if we remove the vitreous, then vessels cannot grow anteriorly, and we prevent essentially retinal detachments in diabetics. So here you see how I am lifting all the tissue very, very slowly in a controlled fashion so as not to create breaks. When I see some resistance, I stop and I continue lifting it up and then removing everything with the probe. Once we do this, I apply laser. Laser is very, very important in diabetics. All diabetics with proliferative disease should have panretinal photocoagulation throughout the whole retina. Anti-VEGFs is not a substitute for laser photocoagulation. Really, diabetics need laser. And here I'm checking to see if there's any more hyaloid present. Sometimes I use perfluorocarbon liquid. This is a case that had multiple surgeries. This was the patient's only eye. And really, it failed because they hadn't removed the hyaloid completely, and it kept detaching. So I'm removing all the traction anteriorly too. But most of the breaks here were more towards the periphery. So I'm injecting perfluorocarbon liquid to flatten everything and leave it as flattened as possible. And even though this patient, it was his only eye, I left gas because he already had 4 surgeries before me. So I just left some SF6. I told the patient that he wouldn't see much for about a week and a half, but he did really, really well. And that way he avoided having a second surgery to remove oil. This is the technique that I described. I used to use a lot of visco dissection. So this is like doing visco dissection, but with the vitrectomy probe. I find a plane and then I blunt dissect to the sides to lift the tissue from the retinal surface, and then I start cutting. Here I'm using the probe as forceps. to lift the tissue from the surface of the retina. See, I advance it and then I back cut, keeping the opening of the vitrectomy probe anteriorly towards me. That way I will not create breaks as I go along. And this is a very, very nice technique to have in your armamentarium. Sometimes you have a case like this where everything is plastered. We don't really, it's so attached, the hyaloid, to the whole retina that there's no plane to start in the periphery. So what I do is what I showed here. I detach the hyaloid over the optic nerve and I start the dissection from the inside out. I call this inside out dissection. And it is a very nice technique because once you detach the hyaloid around the optic nerve, you will instantaneously have the correct plane to do all this. This is an old case that I had done 23. I would do these cases now all with 27. Minimal dissection. This technique occurred to me because of a case that looked very much like this, had this avascular fibrous tissue covering the whole retina. And I did one eye of a patient, and that eye, I lost that eye. And the other eye looked very much like this, and the patient kept insisting that he wanted something done because he kept losing vision because of the opacity of the hyaloid over the fovea. So it occurred to me to open the area around the fovea and do those relaxing incisions towards the periphery without having to remove everything. Because trying to remove everything in a case like this could very likely create breaks. And this is a technique that now I use in these very, very challenging cases where the fovea is attached under this whole sheet of fibrous tissue to give them vision. The trick is really to remove all of the adhesions of the hyaloid to these plaques and do the relaxing incisions towards the periphery in several places so that the circumferential traction will not continue. In this case, attain really good vision, and these eyes stay stable forever without having to use oil or anything else. This is one of the cases I did recently with the Alcon Unity system, but on 27 gauge. And here what I'm doing is I am removing all of the traction around. You know, many of these cases have these circumferential sheets of fibrovascular tissue. And the trick is to dissect them, segment them so that the centripetal traction does not continue. So this is what I'm doing here. You see how much traction there is because when I cut it, the tissue retracts like a spring. So here I'm removing, isolating everything so that traction does not continue. This is the only eye of this patient. So here I'm just doing whatever, only what I think is needed to remove all the continuing traction. I'm applying more laser to the periphery, removing everything. And I left here, I left oil in this case because this was the only eye of the patient. I love using 3D viewing on 27 gauge. Here, this is the only eye of a type 1 diabetic patient, had massive hemorrhage. She had lost the other eye to surgery elsewhere, and she was very adamant of having surgery done, but you know, she was not seeing anything, and I finally convinced her to have something done. And here I am blowing out the blood with reflux, which works well when you have, you know, massive amounts of blood like here. And then I use the probe to slowly lift this fibrovascular tissue from the retinal surface. I prefer doing it this way rather than using forceps because it's much more controlled. And if the tissue is very adherent to the retina, it's almost impossible to cause breaks because there's not enough force in the 27 gauge vitrector. So I keep very slowly, you know, removing everything. I lift a little bit. Once I lift some and I see that it's separated, then I start cutting. And as I go along, you know, very slowly, always with the opening towards me. And with this technique, I was able to remove all of the fibrovascular tissue from this surface And here I am removing it from the vessels itself in a very controlled way. This is what I really like about 27, that I'm aspirating all of the blood that's left on the surface of the retina. And 6 months post-op, this patient was 20/40, and she had a really nice result and a very stable eye. I like using the highest cutting rate possible, but this is really the technique I use. I remove all of the hyaloid in the periphery to isolate the plaques that are left, and then I lift them a little bit. When I feel some resistance, I stop and I just eat whatever I have safely lifted from the retina. I aspirate the blood to see better. Then I use the probe, the 27 probe, under the retina as if it were scissors to cut those attachments of the vessels to the big plaque. I segment that around. I get under the tissue and basically cut everything. And this is a really nice way of doing this, you know, pretty quickly with minimal risk. Then I aspirate the blood. I put air in, and this is how that patient looked, you know, later. I really like using 3D. This is another case that I did recently. And here you see how, you know, the retina's dragged. There's like some breaks there. The hyaloid is still like attached over the surface of the retina. And I very slowly get under it with the probe, and I advance around, essentially segmenting everything. We can still see the hyaloid over the posterior pole, and I blunt dissect that. So essentially it's just, you know, removing everything from the vessels so that there will not be any progressive contraction and progressive traction causing detachments, you know, later on. I always keep the opening towards me, and this is really a very nice technique. Sometimes we get unusual cases like this one. This case, the OCT is always important because we knew that the fovea was detached. And here, what I'm doing, it had all this dragging, it had almost like retinoschisis towards the periphery with all these breaks, but the whole tissue was dragged towards the periphery. So what I'm doing is I am scleral depressing myself and just cutting all that tissue so that it wouldn't be dragged more, and relieving all the traction, which was mostly peripheral. This was a very unusual case, but you know, you will experience some cases like this. So after removing everything, there was still a sheet of hyaloid over the fovea. I'm removing that to relieve all the traction in the posterior pole. I'm doing this here with forceps. And then those vessels were dragged. I am diathermizing them and cutting them and just removing all of the tissue anteriorly. You see here the schisis and the several layers of retina there. So once I relieve all the traction, I do laser because there was some fibrovascular tissue and neovascularization in the periphery. I'm making sure that I cauterize everything. I'm using laser for this. I do a fluid air exchange, you know, aspirating everything to make sure that there's no traction left in this eye. I'm making sure that then I apply more laser once the retina is flattened to all that area. And I left gas in this eye, and this eye did very nicely. Sometimes I use intraoperative fluorescein in cases that have recurrent hemorrhages. It is a useful technique because you can pretty much see where you have neovessels, where you have ischemia, and where there's still oozing of fluid. Sometimes it's not apparent, you know, in the clinic, especially if you have vitreous hemorrhage. And then you can apply focused laser to those areas during the surgery, as you see here. But remember, the hyaloid is the enemy. When we have an eye of a diabetic that has a complete vitreous detachment in this study, the retinopathy does not progress, and those eyes will never get a traction retinal detachment. But when the hyaloid is attached or partly attached, those eyes will usually progress with progression of traction retinal detachment. And they can progress very quickly. This is a patient during the pandemic that was scheduled for surgery, and in just 6 weeks developed all that fibrovascular tissue. This is another eye doing exactly the same thing in just 8 weeks. So these cases we want to do very, very early. And we know that earlier vitrectomy gives you better results, particularly in type 1 diabetics. The DRBS showed this in 1985, even though we did not have really good instruments at the time. So advantages of early vitrectomy is that really it stabilizes the eyes permanently once you leave them stable. And we have to, think outside of the box. Surgery should not be the last resort because vitrectomy really stabilizes eyes long-term. This is 12 years afterwards. And maybe, earlier vitrectomy is what we should be thinking about when we see patients, especially with an attached hyaloid. So when you look at a diabetic, just look at the hyaloid. The hyaloid will tell you everything. If the hyaloid is attached, removing the earlier vitrectomy would work. If you have a patient with proliferative diabetic retinopathy, the treatment is PRP. You should laser those eyes because laser will stabilize most eyes, especially if the hyaloid is detached or, earlier on. I reserve anti-VEGFs just for macular edema. But in every patient that has proliferative diabetic retinopathy, I always do PRP because PRP will prevent them from having, in many cases, advancement of disease and traction retinal detachments. And really, we have to tailor our treatments to the reality of the patient. If you have a patient that comes from far away and you just has some retinopathy, you may not see them again. They don't have insurance or whatever. PRP has a very, very important role. Just PRP all those eyes and you will save many eyes. If you have a patient that already has an attached hyaloid, has been bleeding a little bit, then earlier vitrectomy is something we should consider. Anti-VEGFs should never be used as the only treatment in patients with proliferative diabetic retinopathy. And also, we know that in diabetics, anti-VEGFs used regularly increase the risk of death in many of the studies that we have seen. So always, always think of the status of the vitreous. Remember that laser is the standard treatment for proliferative diabetic retinopathy, and early vitrectomy should always be considered. So whenever you look at an eye, think about the hyaloid, think outside of the box, always go to the operating room with a plan, be meticulous, and adapt to changing conditions as you go along. So many thanks for you for being here, and many thanks to everybody for inviting me. Thank you so much.
Thank you, ma'am, for sharing all these wonderful cases. So I have a few questions. So do you do ILM peeling in the cases of minimal dissection also?
No, I don't use ILM peeling. I don't feel it's necessary. And sometimes, many diabetics have a lot of ischemia already. So removing the ILM, and oftentimes they have, they have had edema, they have cystinuria, so removing the ILM can cause you an iatrogenic macular hole or a macular hole later on.
And do you give anti-VEGFs before operating a TRD, or you directly go in?
Actually, I don't. I used to all the time. And then I started noticing that removing the membranes was much harder because anti-VEGF, what it does, it increases the fibrosis. It causes a fibrous switch. So the tissue becomes much more fibrous and much more adherent. You saw in many of these cases how easy that fibrovascular tissue peels because it hasn't had those fibrous adhesions formed. So I think in the last year, I may have used it once in a case that was super vascular, but now with small gauge and the way we can control the pressure with the newer machines, you can really control bleeding much better without needing it.
Thank you.
Hi, ma'am. This is Dr. Isha. It was a wonderful talk, ma'am. Just a few questions like, are you using bimanual technique or
I
Chandler?
sometimes do. I do by manual technique, especially when it's a combined traction and rhegmatogenous. You
Okay.
need bimanual techniques because the retina is all floppy, detached. So I use a chandelier. And then oftentimes for bimanual technique, I use the forceps in one hand, and then the vitrector, I use it as scissors. Because the 27 gauge vitrector, you can use it to dissect, you can use it to pull, you can use it as a multi-use instrument.
Sure. Thank you, ma'am.
Hi, Dr. Barakul. Thank you very much. Wonderful presentation. I know not to create a break is the motto here, but when there is a break, how do you handle this? Do you have any tips on that? Especially if the break is like at the very severe traction site.
Yes. Once you create a break, the first thing that I do is I mark it with diathermy, because if it starts bleeding or whatever, then you're not going to see it. But once you create a break, you have to remove all the tissue. You cannot do a minimal dissection like I was showing. You cannot leave a lot of tissue around because the contraction will continue. So then, you have to then use bimanual techniques and try to remove all the traction, not necessarily everywhere, but at least in that quadrant, so that the retina settles well. And then, if I'm leaving, if I cannot remove everything in other areas, I am more prone to use silicone oil. I normally don't like silicone oil as much in diabetics because if it, most cases rebleed a little bit. And if they rebleed, then you get like more membranes forming. I tend to prefer gas, but in those cases, I would use oil. The reason I like gas is because a lot of these patients will rebleed a little bit. And if you don't have oil and they rebleed, you can do a fluid air exchange in the office, which I have a video of it in iTube, and it's a really great technique to clear blood in a vitrectomized eye. I do an exchange. It takes like a minute to do. You can look at that video. It's really simple. It's just a 10 cc syringe with a 27 gauge needle. And I do it in the office, bending, the patient sideways. And sometimes when I do that, I inject anti-VEGF then in a vitrectomized side to prevent, rebleeding. But it's a nice
Thank you.
technique to do, which will save you taking them to the operating room again.
I'm gonna check your video. Thank you.
Hello, Maria.
Dr.
This is Barbara.
Barbara, I loved your talk, by the way.
Thank you. I'm sorry I'm late.
No, don't worry, but your talk was great.
Thank you. Thank you. If you have questions, I'm here. Actually, my comment to you is that I totally agree on the need and beauty of early vitrectomy. I think the only drawbacks that I have found is that some patients also have macular edema, and in those cases, the anti-VEGF timing, the anti-VEGF benefit lasts less because there's no vitreous to contain the drug. Probably that's the only thing you have to inject them more, unfortunately. And
what I do in those cases is I leave triamcinolone at the end.
Okay.
In the vitreous, because triamcinolone works very well in those cases, or you can use Ozurdex afterwards.
Okay. Yeah.
Alternated. And also removing the hyaloid, sometimes if you remove the hyaloid, oftentimes the edema gets better.
Oh, no, I totally agree. Yeah. And I have found a good use of tranexamic acid for the bleeding. It's helping a lot. And also for the idea of patching, I have been using that also in some diabetic, in which I created a break over subretinal hemorrhages. So I didn't know how to deal with them because there was blood underneath, and I didn't want to aspirate the blood because I was afraid to enlarge the break. So I decided to try the patch, and so it could be another good I don't know. I have almost 2 years now of follow-up with the tutor patch. In summary, I've seen that it's not causing inflammation, and they did not develop PVR, but I think silicone oil is useful in those cases to keep the patch in place. I have a couple of cases under air and gas, and I observed some dislocation. So
yeah, you need oil. You need oil if you're using the patch, but the patch is a great idea. Yeah.
let's hope it works. All right.
Maria, thank you for a great quote. I enjoyed your talk. It's a fantastic one. It's great also that you highlighted the role that PRP still has a role. We're all rushing
Yeah.
giving injections, but
True.
definitely following up the patients in the office and those type of patients that don't come frequently. It's definitely operating later on an eye that had PRP than operating on an eye that had multiple anti-VEGF injections. That's an
Yeah.
excellent point.
I agree completely. I think we are blinding many eyes that have proliferative diabetic retinopathy by treating them just with anti-VEGF, because the moment they miss an appointment, they come back with neovascular glaucoma.
Yeah.
And then those eyes are completely lost. Whenever I see a patient, even if I'm taking them to the OR, a patient comes with, some traction detachment. I PRP all the periphery before. It makes my surgery easier. It makes the periphery, a much more stable environment. I PRP them in the office, and then I take them to the OR in a week or 2 weeks.
Yeah.
But yes, I think, I see so many eyes lost because, patients, but even the most reliable patient, you or I, you mean to go next week, maybe you're in a car accident, maybe you get hospitalized, maybe you get a stroke, and then you lose your eyes because you get the rebound neovascularization. So I think that is the most important point that I want to make. And if you have a patient that traveled, let's say 5 hours to see you, he is poor, he just has some retinopathy, and you may not see them in a year, I would PRP those eyes. If it were my eye, that is what I would have done to myself. I always think when I see a patient, what would I do to myself? And you have to understand that diabetic patients get really ill, and they, when we started using anti-VEGFs, I had a patient that I started PRP on him, and I started anti-VEGF too because he had macular edema. I had only done like half of the PRP. And that patient was hospitalized for 3 months, and he came back with a massive traction and rhegmatogenous detachment. I published it because it is not the natural history of the disease. This progression was huge, and it is because anti-VEGFs give you a rebound effect when you stop it suddenly. So these are things that we have to think that PRP for proliferative diabetic retinopathy is the standard treatment. Anti-VEGFs are great for edema, for macular edema, but it doesn't take the place of PRP.
Actually, Maria, I have another comment because I so totally agree with what you said. There was a time where we thought that vitrectomy could be enough, just the removal of the vitreous, because there was this theory about the oxygenation of the retina due to vitrectomy. So I did a few cases, and they don't develop traction retina detachment, but they develop new vessel in the iris anyway.
Yes,
So this
yes.
is to prove that the only
We need
way to get
PRP.
rid of it is PRP. Yes.
Yeah.
Because we
Yes.
don't get rid of the ischemia. We're just getting rid of the traction. When you do vitrectomy, you're using the traction, but the ischemia is an ongoing
Exactly.
process, and you have to ablate the retina.
Yes, yes. And it is a permanent treatment. You do a PRP, these eyes are cured forever, most of them, especially if the hyaloid is not there, so, condemning an eye to coming in and getting an injection every month or two, when we know that the mortality is higher. If you look at Protocol S, the mortality was twice as much especially cardiac mortality in patients in the anti-VEGF arm than in the laser arm. And this is something that we don't think about, but diabetic patients do have a higher risk of cardiovascular risk factors, and anti-VEGFs do increase that in that population. Not so much in the AMD patients, but in the diabetic patients, yes. These are all things that we need to think about, when we see a
Yes,
patient.
right. Yes, definitely.
Thank you, Dr. Maria, for your great talk. As Dr. Barbara is with us, a couple of quick questions from the panel to Dr. Barbara on her talk on TutoPatch.
Okay.
Dr.
Anybody?
Parolini, thank you.
Yeah,
Thank you
please,
very
please.
much. It was an inspiring presentation. So I was really curious how the pericardium behaves over time, if it integrates into the underlying tissue, kind of like an amniotic membrane, because I wonder if it's stable enough when you remove the silicone oil, if it will remain in place or not.
Yes, good question. I'm discovering the behavior in these months. As I was saying, my first patient was operated 2 years ago. So I removed the oil in, I think by now I have collected 20 patients, something between 20 and 30. And I have removed the oil in half of them. And so I try to touch the patch after removing the oil, and it sticks to the tissue underneath. There are no membranes surrounding the patch. Another thing that I have discovered, as I said, silicone oil is important. I have inserted the patch under silicone oil where the oil was already inside. I think it's the easiest way because you have a good view and you place it exactly where you want. I tried under PFCL and I tried under air. Still, you can place it where you like, but under air or gas, I found displacement. And so I'm not advising to use that tamponade. Also, TutoPatch in particular has two sides, a smooth one and a rough one. So I have discovered in one patient that where I placed, because I was not paying attention to the sides, the smooth is not a good idea to touch it's better to touch the choroid with the rough surface because in time there is a small shrinkage of, not shrinkage is too much, but the edges might elevate toward the smooth part. So it's better to touch the choroid with the rough part. That's it. And as I said in my talk, I don't think it's about TutoPatch. I think maybe amniotic membrane could do the same, or maybe there are other and better tissues. This is the one that I have access to, and I saw that it's not toxic. It does not induce bad side effects. So this is the one that I am using because it's very, very practical. But maybe there are other tissues that could work even better. I think the idea is just about covering the atrophic areas in myopic eye and covering the choroid to prevent PVR.
Thank you very much. Great tips.
Thank you, ma'am. So just one question. Well, in Italy, what is the cost of the TutoPatch? And is it universally available? I mean,
this is a tough question for me. I've seen it used in different ORs in different parts of the world, especially to cover, for example, glaucoma valves or to support the sclera for other indication, mostly for the sclera. And this is the indication for which I was using TutoPatch. For example, when I operate myopic eyes and I implant the macular buccal, if I see that the sclera is very thin, I place a TutoPatch reinforcement on the scleral wall. So anyway, it comes in different sizes, so the cost depends on the size. But I mean, it's a few €100, like in the range of €200, something like that, for a large patch. So it's not really expensive. If you have a large one and you're able to isolate the small patch that you need, it's not expensive.
Okay. And any displacement you have encountered post-operatively, especially these anterior breaks, it's got a weight and sometimes it can.
Only in the case if you use silicone oils, you don't see displacement even with large patches and even for large areas and even in the periphery. You can have displacement if you have used air or gas.
Okay. Great. Thank you. Thank you so much, ma'am.
Welcome. Thank you. And congratulations for the organization of the web meeting. Thank you, everyone.
Thank you. So we move on to our next speaker. It's my honor to introduce Dr. Ehab El-Reyes. So he's a professor of ophthalmology and chairman of the retina service at the Institute of Ophthalmology in Cairo, Egypt. Other than being a prolific VR surgeon who has won awards, who's trained multiple fellows, he's also the innovator of the 23-gauge fragmentome and suprachoroidal techniques. And we'll be hearing about that today. And his topic is transconjunctival suprachoroidal buckling. Over to you, Dr. Ehab. Hoping for a great learning. Yeah.
Thank you, Shashir. Well, my talk today, can you see the screen, right? Can you see the screen?
Yes.
Okay. Well, remember that these are my financial disclosures for the topic I'm going to speak about today. About 12 or 13 years ago, I showed for the first time that it is possible to treat retinal breaks through injecting a filler to dissect the choroid and let the choroid support the retina for retinal breaks. And that was a method that we showed that could treat retinal breaks as well as retinal detachment. And we had several publications over the last 13 years of this technique. A step after that, we developed that olive tip cannula that used to go in the suprachoroidal space, but that necessitated that we open the conjunctiva and a small incision in the sclera right underneath the area of the break. Then we insert the olive tip, which is an atraumatic tip, underneath the choroid in the suprachoroidal space to inject the filler, push the choroid, and support retinal breaks or close retinal breaks, as you can see here. Then we do the cryo before and close a retinal break to treat retinal detachment. That technique we've been using for quite some time since then. A step ahead, we thought that could we do the same technique transconjunctivally without the need to open the conjunctiva, neither the sclera, and would this initiate an office-based procedure for retinal detachment? We developed this new transconjunctival cannula that you can see. It has an olive tip at the end to indent with and to be atraumatic while sliding over the conjunctiva and sclera. Then it has a rounded Atkinson needle 25 gauge to puncture the conjunctiva and the sclera without damaging the choroidal tissue to inject the filler inside the eye. So it has an olive tip to indent first, then to puncture. The concept, again, this is the new prototype of the cannula, and you can see that you use it if, for example, an inferior break, you go with the side with the olive tip indenting while you see from the inside of the eye till you reach underneath the break. Then you rotate your handle. So now the tip of the needle is against the conjunctiva and the sclera to puncture. When you push, there is resistance because this tip is not cutting, it's rounded, so it's difficult to puncture the sclera, and it ends up underneath the choroid to inject the filler. What type of filler we'll be using? There are several things that we have available, but I personally prefer the Restylane, which lasts up to 14 months, but of course you can use Helon 5 or Helon Pro, which lasts 2 to 3 weeks. This is the Restylane. It's nothing but hyaluronic acid, but it has more stabilization, so it lasts longer than the regular hyaluronic acids that we have already. What you do is you connect the filler, the hyaluronic acid, to the side of the tube, and you start injecting to prime the catheter so it's filled all the way up to the tip with the filler before attempting doing this procedure. In the initial cases, we were doing it in the OR underneath the chandelier light first until we got confidence about moving this technique into an office-based procedure. You can see that the filler, once it comes, it's like a jello or like a bubble, and it lasts because it indents and lasts. So this is a patient, for example, that has both superior and inferior retinal breaks, 2 breaks inferiorly and 1 break superior. You can see them here. So we decided to do this technique. What we do is we just put a chandelier light and use the biome system, and we slide the catheter on the side, indenting the tears first there. Once I'm underneath the tear and I can see I'm in the correct plane, then I will rotate my hand, and you will see in a minute that when I push there, that's the needle underneath the choroid in the correct plane. Then I ask the assistant to inject. The filler lifts up like you're placing a buckle, a regular plum or a circumferential buckle accordingly. So now I inject the filler, so 2 breaks on 1 buckle here. Then I move to the upper break again with the side. I indent while looking inside the eye. And once I see the superior break, I rotate my hand, puncture there again through the sclera underneath the choroid to inject the filler. And now I have 2 buckles placed, 1 superior and 1 inferior. In most of these cases, once you close the tear, you don't need to drain, but you just need to put an air bubble. What would this look like? This is the first week 1, and you can see on the right-hand side, the buckle with the laser done in the office 2 days after. The fluid is gone, and you put your laser to close these breaks. This is taken 1 week after. And you can see the areas of the indentation created by the filler, which lasts up to 14 months, enough to create chorioretinal adhesion within the first 2 weeks. You can see it here. Would this also work with vitrectomy, for example, cases with inferior PVR? This is, for example, a case that had myopia and bad inferior PVR with star folds inferiorly. Of course, in this case, you can just do a vitrectomy. Then you might need to do a retinectomy. But what with the other option? I decided in this patient, after cleaning as much as possible, to support these inferior breaks by placing a buckle at the end of surgery. It's a procedure that takes 2 minutes to inject the support, like placing an inferior buckle in a second here for this inferior break. Then this patient had multiple breaks also at 10 and 3 o'clock. So I again indent at 10 o'clock or 3 there, inject. And once I'm in the correct plane, inject another bubble here. So all the breaks that are visible or traction, you could counteract them by placing a buckle like here. Of course, in such a situation, once you support these tears, you won't need a long-acting tamponade, especially when you have inferior retinal breaks with PVR that necessitates putting a tamponade and sometimes doing retinectomy. This is a good option to counteract the traction that is residual and close these tears immediately without the need to put any tamponade inside. So since you're doing it without opening the conjunctiva, you can do more than 1 injecting, supporting whatever number of breaks that you will have, all by injecting them directly and supporting the retina immediately while doing vitrectomy. What about taking a step ahead? Could it be an office-based procedure? The answer is yes. This is a patient, for example, that had a superior break. You can see the upper slide here. He has a large break present. So after doing the same thing that we did, this patient, you prime the catheter again and giving numbing anesthesia, or you can give retrobulbar if you prefer. Once it's there, you can use the indirect ophthalmoscope to use the same technique while looking through the indirect ophthalmoscope. Where is the tear? And right underneath the tear, you do the injection. This is done in the OR, but of course, the next patient I'll show you, you do it in the office. Once you're in the correct plane, you, of course, need to have a clear media, a good widely dilated pupil, and you should master, of course, as we all do, a scleral indentation. Once in the correct plane, underneath the tear indented there, I rotate my hand, do the puncture, then tell my assistant start doing the injection to lift the choroid to close that superior break, which I had. You can do the laser if you have an indirect laser right in the same session, or a day later, once the fluid goes away, you can put your laser inside the eye. And this is a very simple technique. It takes 5 to 10 minutes and the patient is done. You can sometimes tap the AC if the pressure is too high, or you can put an air bubble after that. What would this look like? Looks like this. The first post-operative day, you can see that the small air bubble superiorly, and that's the suprachoroidal dome that is created, closing the superior break, and the fluid is gone. You can put your laser on, and this is how it looks like. Very simple procedure, takes 10 minutes to do it. This is another patient that had a big temporal break superiorly. You can see that we're doing the same thing. This is office-based now in the office. You just prime the catheter, and the same thing while the indirect ophthalmoscope. Where is the tear? I look for the tear. Once I'm in the correct plane, we start doing the same thing, inject to close the tear. This is after closing the tear. You can see the superior dome created before putting the laser. And a couple of days later, we put the laser and everything is done. You can do it even with the indirect ophthalmoscope. You can just wear the indirect ophthalmoscope and do it in the same thing. If you don't have too much fluid and there is no need to drain, you can put the indirect laser on, inject, and at the same time do your laser. There are certain difficulties. The first, if you inject too shallow, then the filler will go underneath the tenon or the conjunctiva, then you need to drain it because it's going to stay there if you don't drain the fluid. If you go too deep, you might puncture the choroid, and that's what you get, what we call the choroidal dot hemorrhage. Why it doesn't choroidal hemorrhage? Because it's under pressure, and usually the needle that we're using is 25 gauge, the same as giving intravitreal injections, so there is no risk or there's no fear from having trickling of the blood underneath the cannula because you can easily indent and stop the hemorrhage immediately. You end up by having that dot-shaped hemorrhage inside the eye. The correct plane is what we call choroidal dimpling, is looking at that stainless steel tip underneath the choroid. That's the correct plane to start doing your injection. We did a clinical trial in which we included 36 patients. These patients had both superior and inferior breaks and multiple breaks. And we found that 81% of them, we did them in the OR just by using a chandelier light or using indirect ophthalmoscope. 19% of the patients were done outpatient in the office. And these patients did have both superior, inferior retinal breaks, multiple breaks, one single break. So there was a variety of the indications included. Retinal reattachment was achieved in 91% from doing it in one procedure. 9% required a second injection, 3 patients. And these were the initial phase in which we're still learning the curve in how we do it correctly and the amount that we need to inject inside the eye. A good case to start is supporting a case during a vitrectomy. This is the easiest way. If you're doing a vitrectomy and you see a break that you need to support, you can start doing it like this. The second step ahead is just put a chandelier light and to treat 1 or 2 breaks with a shallow retinal attachment. When you're comfortable with this technique, then you can start using the indirect ophthalmoscope and doing it as an office-based procedure. For that, I would pick a patient that has 1 or 2 breaks with shallow fluid and widely dilated pupil clear media. So in conclusion, transconjunctival suprachoroidal buckling is a minimally invasive option for managing retinal breaks. It could be done seldomly just by using an indirect ophthalmoscope or a chandelier light, or you can use it during a vitrectomy to support inferior retinal breaks, avoiding the need of tamponades, especially with inferior retinal attachment, office-based procedure with the proper case selection, and avoid some of the potential problems of scleral buckling or vitrectomy. Thank you so much for your attention.
Thank you so much, sir. That was a great presentation. So the olive tip cannula, that it's got a kind of a stopper which prevents it further penetration and going through the choroid, right?
There are 2 things that protect the choroid. The first is the tip of the needle itself is Atkinson needle. It's not a cutting needle. So there is a much resistance trying to push because it's rounded at the tip. So once you puncture, there is always a pop that you feel it. The pop is the length of the needle going through the sclera. It doesn't go 2 more because already the length of the needle is shorter than the tissue. The second point is the olive sets on the sclera. So it's a defensive mechanism. And even if you go too deep, like some patients, there is scleral thickness variation from one point to another. If it goes too deep, you see it directly. So you see the tip of the needle. If it starts showing in the choroid, then I retract before attempting the injection. So the most important thing is you see it. Some other needles that were used before, like giving drugs or whatever, you do it without seeing the tip, and it's a cutting needle. But this one is Atkinson. It's like giving the anesthesia, it's rounded. And at the same time, you have to see where you're going to inject, and the length is protection for going too deep.
Great. So it's gonna, and you made it an office-based procedure, so it's gonna compete with pneumatic retinopexy.
There's certain different pneumatic retinopexy. You can't do pneumatic for inferior break, and even if you do it for inferior break, if you don't close the tear, then you're high risk of having a redetachment. But this is a buckle. It's a buckle. You close the tear immediately on table, and you see it because you can control how high it. So the indications, even if you have a patient that has several breaks, you can give multiple injections because at the end it's an injection technique, and you see where you're injecting and you see what you're buckling.
And it's easy to laser also. You can laser it on the table also if required. Whereas
if there is no fluid, if you manage to close the tear on table, there is no too much fluid, then I use the indirect laser immediately. But if there was fluid enough to prevent my chorioretinal adhesion, I inject an air bubble, take the patient to the office 48 hours later. Once it's dry, then I do the laser in the office.
Okay, great. Thank you. Thank you, sir. Any questions from the panel moderators? Anybody? Dr. Eche, you are muted.
Yes, thank you very much, Dr. Reyes. It's a great technique. Thanks for sharing with us. I was a bit concerned about the PVR case you showed. If we use Helon 5, for example, it will stay for 2 to 3 weeks, and would it be enough time for it to be contracted enough and will not recur, or should we use a longer affecting tamponade for that cases?
That's an excellent comment. Definitely for cases that, how long does it need to create a choroidal adhesion? 7 to 10 days. So if I'm using a regular case with no PVR, I just inject Helon 5. Helon 5 or Helon Pro is enough. But if I need to place a high buckle for quite some time, then I will use the Restylane, which I just showed you, because it's lasts there 14 weeks. And at the same time, this is not an alternative for treating PVR. You are supporting an inferior break, but the main concept, if I use it with a vitrectomy, I'm already doing a vitrectomy, cleaning everything. But instead of putting a retinectomy for that area, like when you used to put circumferential buckle for inferior breaks, it is the same concept. I will then counteract any residual traction, avoid doing retinectomy by supporting the inferior retina with a long-acting buckle or tamponade.
Okay, thank you.
Thank you.
Shishir, I have a question to Dr. Heb.
Yes, sir. Please go ahead.
Dr. Heb, extremely wonderful talk. It was very inspiring to see the technique. For the office procedure, you've been using this instrument. Is there any way that we can get our hands onto it, or can we do some modifications in the in whatever inventory we have?
Well, I showed you the prototype we are developing. I think that maybe by end of December, according to the manufacturer company, we might have it already available in the market. For the time being, we have originally the suprachoroidal olive tip, which is already available, and that is made for scleral cut down. So you can do that if you open the conch and the sclera, then you inject the filler. This one is already available by Med1 company. But a little bit down the road, we will also have the same company developing this new one, which is a transconjunctival. It will be available maybe by the end of December or early next year for anybody. But of course, you're more than welcome to try it. We can send you prototypes to start using this.
Thank you, sir. Thank you so much.
You're more than welcome.
Any other questions to Dr. Ayab from the moderator?
I have a last question. Can I ask?
Yes, please go ahead.
Great talk, sir. Just a small question. Do you drain anytime after putting the subchoroidal injection?
Yes, as a matter of fact, we have like a series now already past like 50 or 60 patients, and I would say that maybe 10 patients we need to drain. How do we drain if we want to keep it as a closed system like this? We use a 27 gauge needle before we inject the filler, go in the same quadrant in which I have the highest bullous retina, go through the sclera, through the choroid, then drain passively. So once the fluid starts trickling out of the needle, I remove the needle, then start going with the other cannula, which is the suprachoroidal cannula, to buckle the tear. So you don't need to drain it bone dry, but you need to decrease the amount of fluid, to decrease the amount of the filler that you need to inject to lift the choroid to close the tear. So if I have a high bullous detachment, I would initially drain a little bit passively so that you don't have too much gusher fluid until you have like good soft tension. You don't need it too soft. Then I put the cannula and start lifting the choroid to close the tear. But you can drain in the same procedure.
Thank you.
Great. Any final question? Then we can, if not, we can close the session because we are already over the time limit.
Thank you, everybody.
Thank you. Thank you so much. Thank you, moderators, panelists, for your questions and making this a great session. Thank you.
Thank you very much.
I think, Dr. Shishir, I will move ahead with our session.
Yes, please go
on
ahead.
surgical dilemmas.
Sure.
So I welcome all the panel. Dr. Vivek, Dr. Nasim is on the flight, Dr. Pablo Cibles. I warmly welcome everyone to this unraveling surgical dilemmas. Dr. Adel, a warm welcome to all of you. So without wasting any further time, I would like to share Dr. Naseem's video. And Dr. Naseem Abreu is a surgeon par excellence, and he is basically an assistant associate professor of ophthalmology and retina department at Dr. Elias Santana Santo Domingo at Dominican Republic. So he will be talking on how to fight PBR with one injection at a time. So let me share this talk, and let me know if the audio is coming.
So thank you very much to the organizing committee for this kind invitation.
Can you hear
This is
the
my
voice?
second time
Yes,
in the
it's clear.
Ophthalmologica webinar series, and I'm very grateful for that. I've got no financial disclosures for this talk. Retinal detachment surgery success has come a long way the last 50 years. Despite the advances, PVR is still a threat in around 10% of all surgeries. Intravitreal methotrexate has proven to control the appearance of PVR, but the burden of the current protocols is high. Many injections are required, and in some of these protocols, weekly visits are mandatory. For those that lack easy access to healthcare or who live far away and have to travel for many hours, these protocols may not suit them. This is why we wanted to explore the possibility of lowering the amount of injections while achieving higher success rates in complex RDs. So we set out to determine the efficacy of reduced amount of injections of intravitreal methotrexate treating complex retinitis retinal detachment with signs of proliferative vitreoretinopathy. Our secondary endpoints were to determine which injection scheme of intravitreal MTX is more effective preventing PVR, determining if the differences between primary retinal detachments versus redetachments were when using MTX, identify the overall retinal reattachment rate, and to define the side effects for each MTX group. So this was a prospective interventional randomized and single center study that had 4 groups, where group 1 had only 1 injection of methotrexate, group 2 had 3 injections, and group 3 had 6 injections, where group 4 served as control. We included primary rhegmatogenous retinal detachment with a minimum PVR grade of C1, recurrent rhegmatogenous RDs, and all the patients should be 18 years or older. We excluded TRDs, history of other ocular diseases, and failure to complete follow-up. So our injection and follow-up protocol was the following. All the study groups had their first injections right after the surgery was done, and in the single injection, no more injections were delivered. In the 3 injections and the 6 injection group, the patients were injected after the first injections every 2 weeks until they completed either 3 or 6 injections. And all of the patients had to have a minimum follow-up of 6 months. So we found that 65% of our patients were male, and 56% of all of our patients had an average rate of an average age of between 40 and 60 years. Our groups were evenly, or somewhat evenly, So thank you very much to the organizing committee for this kind invitation. This is my second time in the Ophthalmologica webinar series, and I'm very grateful for this. I've got no financial disclosures for this talk. So retinal detachment.
I hope the audio was audible.
Yes, it was.
So I think after the GUARD trial, we had a lot of interest in using methotrexate, and PVR is been a challenge for all of us in managing complex RDs, especially with more than PVR grade C. So methotrexate is known to suppress the inflammation and inhibit cellular replication, both of which are very key in the management of pathogenesis of PVR. So my question to the panel, Dr. Vivek, is there anything we can do intraoperatively to reduce the PVR? Since Dr. Naseem is not there, if you can throw some light other than using methotrexate.
Thanks, Ashay. I hope I'm audible. I
Yes,
think
sir.
PVR is one thing which all of us do struggle. The best thing that comes to my mind when we talk of managing PVR is, as far as possible, we should attempt to prevent it. So I think the primary surgery becomes extremely important. If you are faced with a case where you already have PVR that is setting in, I think it would be important to ensure that you have cleared all membranes, even if you require usage of dye, you require usage of stains. And I would say if you see some amount of crumpling in the inferior retina, there's no harm in adding, say, an encerclage belt to your primary vitrectomy. It's like you go full throttle if you see any changes which are pointing towards PVR. Because while methotrexate and other anti-fibrotic agents are in vogue, there are studies. I don't think the evidence is that strong enough for us to be able to imbibe it into our regular practices. And second, it's often that the response to such agents is not predictable. So still you cannot really make a concrete protocol as to where you would use these agents and where you would not use. So it's like a natural healing process by the body, and you're attempting to fight it. I would, from general surgery, I think I would look at it a lot like keloid. You do remove it, but it tends to come back again. So that is what it is. And when it comes to recurrent PVR, I think that is where you go one step further and do your relaxing retinotomies, or be it circumferential, be it radial, as far as possible, telling yourself that my aim is to save the retina posterior to the equator. If it requires me to sacrifice the peripheral retina to ensure that there is adequate laxity, so be it. So I think that is where the approach lies.
Sir, is like LVPI, you manage a lot of cases which are very complicated. Is there any experience with methotrexate? Because in this talk, Dr. Naseem has used 1 injection, 3 injections, and 6 injections. The GUARD trial already used 8 injections. Is there any experience you would throw some light on?
No, I have, nor my colleagues here have any experience of methotrexate. We did try out anti-VEGF because, again, anti-fibroblastic activity has been noted. There were some studies. We did start off a prospective study for it, but we did not take it to its conclusion because we really did not see it work well. As far as methotrexate or any other anti-fibrotic agents are concerned, our group has no experience.
Thank you, sir. Dr. Adel, do you have any comments on this talk and your experience with methotrexate in your part of the world?
So I can talk about, I mean, what was mentioned by Vivek earlier was very straight to the point. The best way of dealing with them is preventing them to begin with. And I think this is always done by ensuring that you remove all of the hyaloid, making sure that if you have this high suspicion, supporting your surgery with a buckle or a retinectomy, if this is something that you would want to do. In terms of our experience with this injections, honestly, we at least in Riyadh, in this part of Saudi Arabia, we were not privy to be involved in many of the trials that were ongoing, but and I think it's part of the story is that it also carries that burden of coming back for another injection for every couple of weeks, and I think this is why people are shying away from it. So I can tell that the results are not very conclusive, and this is why we're not even starting it at this stage.
Is there anything from the panel who would like to ask any doubts or want to make any comment, or else we'll move to the next speaker. And I think it was a great talk by Dr. Naseem, very valid proposition in the current times where the recurrence has to be taken care of. If there are no other comments, we can move to the next speaker. Dr. Saveen, would you like to introduce the next speaker? Dr. Shraddha?
Good evening, everyone. I would like to call Dr. Pablo Sibles. He's a prominent ophthalmologist from Paraguay, and he is serving president of Paraguayan Society of Retina and Vitreous. Over to you, Dr. Pablo Sibles. Welcome on this forum.
Good morning, everyone. Thank you for the kind invitation. I will share my screen. Okay, can you see?
Yes, sir. You are audible and your slides are visible, sir.
Yeah. I will present a challenging Stickler case, a patient with only one functional eye. Over 3 decades, she underwent multiple surgeries and complications, forcing us to adapt management at every stage. This is a 37-year-old female with suspected Stickler syndrome. She has high myopia of -16 and a history of Lecq-Calvé-Perthes disease. She had retinal detachment in both eyes and underwent several surgeries between the ages of 3 and 11. Her left eye became phtisical, and she first came to me in 2017 at age 28. In 2017, her right eye had 20/30 vision with correction and a normal pressure of 12. The intraocular lens from the 2008 cataract surgery was well centered. And there was a very tight 360-degree buckle, which is visible in the biomicroscopy. And apparently an additional temporal band had been placed, producing a very pronounced indentation with sharp edges directed inward toward the globe. The sclera appeared extremely thin in that region, and there were 360-degree cryo laser scars. In August 2022, after years of close follow-up, the patient reported a superior visual field effect. Her visual acuity had dropped to 20/50 minus, and inferior retinal detachment was detected. A partial vitrectomy was performed, and during surgery, a small fragment of silicone material was extracted from inside the eye. An inferior retinectomy was required to flatten the retina, followed by endolaser, and finally silicone oil was injected. This, because of the extremely thin sclera, the remaining silicone band was left in place. This photo shows the tip of the explant that was removed during the surgery. The left picture is before, and the right is after the surgery. Post-operatively, the retina remained attached and visual acuity was 20/50 plus. However, intraocular pressure increased to 22, which I managed with maximal topical medication. And 6 weeks after surgery, we noticed a dehiscence of the inferotemporal sclerotomy. And oral acetazolamide was added to the topical therapy. And at this stage, vision was around 20/40, and the retina remained attached. Over the following weeks, with IOP around 22, the dehiscence gradually increased. In 2 months after surgery, we performed a scleral patch graft covered with the amniotic membrane. The distal part of the patch was sutured to the silicone buccal. Because there was no viable conjunctiva, we transplanted conjunctiva from the fellow eye, and after surgery, the retina remained attached and vision improved to 20/40, but intraocular pressure stayed elevated. The first patch failed due to partial dehiscence, and after 2 weeks, we placed a new scleral patch covered again with amniotic membrane. And however, another dehiscence developed, and after 6 weeks, a new patch graft was performed, and this time using corneal tissue, not sclera. And following these procedures, visual acuity was 20/30, but intraocular pressure remained elevated around 26 despite maximal therapy. During the following year, intraocular pressure gradually came under control, allowing us to taper the anti-glaucoma medication, and she developed an exposure keratitis. A tarsal strip procedure was performed in March 2024, and in mid-2024, the patient reported blurred vision again. I detected siliconal migration into the anterior chamber, forming a large bubble that progressively increases in size. And by late July, visual acuity had dropped to 20/200. Then I decided to remove the silicone oil. After surgery, vision improved to 20/60 with IOP stabilized at 17. And by late 2024, the eye appeared stable. Visual acuity was 20/60. The corneal patch is stable as well. And intraocular pressure was 12 without any glaucoma medication. However, 8 months after silicone oil removal, the patient again noticed blurred vision. Visual acuity had dropped to 20/100 minus, and intraocular pressure fell to 5. And OCT revealed cystoid macular edema. The retina remained attached, and UBM showed a tilted IOL with superior and temporal iris touch, but similar to the findings observed 3 years earlier. Here you can see the UBM comparative images. I decided to inject an Ozurdex implant due to worsening of cystoid macular edema, and 1 week later, visual acuity improved to 20/80, and OCT showed a marked reduction in edema. But only 6 weeks later, the edema recurred and vision fell again to 20/126, and the dexamethasone implant was no longer visible in the eye after 6 weeks. And given the short duration of effect, the cost, and the lack of commercial availability of Ozurdex in my country, I decided to use intravitreal triamcinolone. And between July and September 2025, the patient received 3 injections. The first injection reduced the macular edema, but vision stayed around 20/126 with persistent hypotony. By the end of July, the edema and subretinal fluid returned, and vision dropped to 20/200. A second triamcinolone injection was given early August, improving the edema and vision to 20/160. In September, the edema recurred once more, and a third injection was administered. By the end of that month, OCT showed partial improvement with vision around 20, 126, but intraocular pressure still only 4. Okay, in conclusion, this eye, recurrent hypotony and cystic macular edema appear multifactorial. A posterior scleral leak is possible at the area of severe thinning where the buccal tip was removed, not detectable by sidal testing. Chronic ciliary body damage from the tight encircling band, ischemia, and long-standing inflammation may also play major roles. In the partial response to steroids confirms an inflammatory component, but persistent hypotony indicates structural dysfunction of the ciliary body, a case that reflects the complexity of long-term retinal survival and the uncertainty of what lies ahead. Thank you very much.
Excellent case. Many things to learn about this case. Stickler syndrome is already a very tough situation to manage these cases, especially the vitrectomy part. It is usually very tough, especially when the breaks are posterior. So what will you suggest? What tips you would like to give to manage such cases with in a Stickler syndrome when the break is just posterior, not very interior? So how you go about that cases?
Yeah. Well, because I saw her when she had many years of after surgery and the very thin sclera, I didn't want to cut the encircling band. But now the challenge is how we will continue, because the first dexamethasone implant worked very well, but only 4 to 6 weeks the duration of effect. Can we continue injecting in a patient like this with dexamethasone implant or triamcinolone, or what other option do you think we can have to manage this case?
If I might comment, this is a very interesting case, Dr. Ferris, and I think this is basically why sometimes you live long enough to see how nice cases sometimes turned out to be not as nice as you deal with them later on. I had somewhat similar case in which this kind of erosion of the choroid and the sclera by the buccal itself and getting it from the inside. But what was very fascinating, and I want your opinion on this, is that this was probably a Stickler case in which the sclera do not behave as a normal one. Do you think this is because it was really tight, or is it just because the band was, or the element was in the eye for a very long time, and the way the eye grew in this eye caused it just to erode eventually?
Yeah, I think we have two components here: the ischemia, because the band was too tight. The ischemia and the erosion, probably the inflammation. When I saw for the first time, it was the video I showed in the presentation. The encircling band was very, the sclera was very thin, but I think that the ischemia plays a major role in this case. But I think the risk of complications trying to cut the encircling band is very high.
I would also want to comment on another aspect of this, because you definitely you're struggling with this cystoid macular edema that's recurring for a very long time. And I had a different case in which I had a similar situation after a buccal. And I was always considering, although we don't have it at home, using the Iluvian, which would stay in the eye for a longer time. I haven't used it, and I think this is something that I don't think you also can answer for, because you also apparently you don't have it available. But what
No.
eventually I ended up doing was that I thought that the inflammation is because of the buccal itself. I had the luxury to remove the buccal because it wasn't that tough like in your current situation. And eventually what ended up happening is that actually the edema resolved because there was an ongoing element caused by this buccal, and probably when I removed it, it went away. Unfortunately, I ended up with a recurrent detachment after I removed the buccal. So I had to deal with this as well. But I think, probably there's that element of the inflammation from the buccal and the cystoid macular edema is caused by this. What do you think?
What do you think is the explanation of the very short duration of action of the dexamethasone implant?
I think one very clear cause is because you don't have vitreous in this eye, so probably the dynamics of the release is different. And I've noticed this even with other patients who I injected with Ozurdex. It does have a shorter action after a vitrectomy. So this is one element. The other thing is that I think you have multi causes of the edema. There's an inflammation, so probably it's just being used more because it's working on different aspects of the eye. So maybe, I don't know, maybe this is why it could help.
Would you consider to put silicone oil again in this eye?
If I wouldn't want to put anything that make me struggle more later on, as long as it's not detached. There's also that element of silicone oil causing some inflammation, probably making the edema by itself just worse with time. So if I can run away from that eye without putting anything else inside it, I would do that.
But it's leading to hypotony, sir. So I think we need to put a oil to save the eye. It's one eye only, no?
Excuse me? What?
This eye was leading to hypotenuse. So we need to put oil, otherwise we will lose the eye. So did you put silicone oil after that, or are you planning to put oil?
Yeah, that's why I'm asking, because
Yeah.
the hypotony, the patient has between 3 and 4 millimeters. The eye is very hypotenuse.
Usually the leftover peripheral vitreous that causes traction to the ciliary body, that's how I think that's the main cause of hypotony. So we need to put oil in certain cases just to salvage the eye. Yes, it will lead to recurrent cystoid macular edema. Yes, but again, saving the eye, I think it's our priority right now. What I think about this case.
Okay.
I'm from the school that thinks that if the eye is just not producing any aqueous and maintaining it, putting an oil inside the eye will not really make that. It will make it build up any pressure. Maybe it will make you feel better because it's inside the eye, but I think if it's gonna go into hypotony, the silicone will escape in the anterior chamber. You end up with corneal issues, and I am sure many of us lived long enough to see that kind of situation in which actually it causes the cornea to become worse, and then it's a different story then.
Okay.
Good luck. We root for you.
Thank you.
Thank you, Dr. Pablo. Any comments from?
I don't know if I'm audible. I had one comment because this was the Stickler syndrome. It's a collagen disorder. So whenever we are putting buckles, it's extremely important to keep this in mind that the sclera can melt. The abnormal collagen below the pressure of the buccal can cause localized thinning. Many times this may not be clinically significant and hence it may not come to our notice. But this is something that you keep in mind as a definite negative finding point. In the sense, if I see a scleral buckled Stickler syndrome, I would look for no evidence of scleral thinning as one of my findings before I sort of sign the patient off. There is one more syndrome called Trebolsi syndrome. I don't know if people have got an opportunity to see. I'm sure most of us will see at least one or two cases in our lives. And they tend to have spontaneous conjunctival filtering blebs if you happen to touch the sclera. So if you make a sclerotomy, 110% money back guarantee you're going to get a filtering bleb there because the sclera there is not going to close and everything inside is going to leak out. And these patients often present with ectopia lentis. So if you plan a pars plana lensectomy, you actually have to go through the limbus or slightly through the cornea and never touch the sclera. So these are all odd cases with collagen disorders, which give us surprises every now and then. Yeah.
As we could see in the sclerotomy that opens after the vitrectomy. Yeah.
Very challenging case.
We will quickly move to the next talk. Dr. Shraddha, you can take over.
Yeah, hello everyone. It's a great honor to be a part of this meeting. I would like to invite Dr. Vivek Dave for the next talk. So Dr. Dave is a distinguished vitreoretinal surgeon and heads the Anand Bajaj Retinal Institute at the prestigious LB Prasad Eye Institute, India. Dr. Dave is also a mentor faculty for Orbis Cyberside and a professor of ophthalmology in Rochester, USA. He has received numerous national and international awards and is actively involved in research and has over 200 podium presentations and over 142 peer review publications in international journals. Today, he will be speaking on role of IOCT in VMTs. Over to you, Dr. Dave.
Thank you, Shraddha. Thank you for that kind introduction, and Team Pan Ophthalmologica for having me over. I've just tweaked the topic a bit because it's a 15-minute slot. So I'll quickly run everyone through vitreomacular traction, when, how, and we top it up with the role of IOCT in such cases. When you talk of vitreomacular traction, it occurs out of abnormal adhesion of the posterior cortical vitreous with the macula. So what this abnormal adhesion does is it causes distortion of the foveal contour. This can result in reduction of visual acuity and or metamorphopsia. So this is what concerns the patient and what brings the patients to us in our clinic. To understand this abnormal adhesion, it's important to know the concept of anomalous PVD. A detailed discussion is out of scope of this talk, but this is a very nice paper. This is one paper which I like a lot and suggest this to all my trainees to read through, which talks of different types of anomalous posterior vitreous detachments and how vitreomacular traction is one subset of this concept. If you look at the etiology, most cases that come to us are idiopathic, but they could also be concurrent in association with underlying age-related macular degeneration, diabetic retinopathy, or retinal vein occlusion. And whatever may be the background etiology, what brings them to the clinic is varied amount of vision loss and sometimes with metamorphopsia. When you see such patients, you may have a subset which is asymptomatic, and when you scan them for XYZ reason, you may find the OCT showing a normal contoured retina, but you will see the posterior hyaloid is attached to the fovea, albeit not really pulling at it. This would be the subset called as vitreomacular adhesion. And as you can see in the right photograph, once the pull starts and the retina starts getting distorted, you call it a vitreomacular traction. So what you saw in the previous photograph was a simple vitreomacular traction. You can also have complex presentations. Here you see a VMT which is still adherent to the retina, as in creating a roof above it, but the inner layers of the retina have opened up and it's like it is covering a macular hole. Or you could have a broad-based vitreomacular traction along with concurrent epiretinal membrane. Sometimes you could have multifocal attachments, which is very commonly seen in a proliferative diabetic retinopathy eye. Or you could have a pull which has been there for such a long time that it really causes one large coalesced cyst with a very thin roof, where there is always a fear of de-roofing it when you're attempting surgery. Or you could have a frank macular hole which has occurred because the VMT has pulled and sheared the retinal tissue through and through. So when you approach such cases, it's important to have a good case selection. Every case of vitreomacular traction would not merit surgery because technically it is not a blinding condition. So what I like to ask the patient is, whatever is your deficit, is it disturbing you? And is it affecting your life functionally? If it is not affecting the life functionally, it is not disturbing, then we can leave it alone. But if the patient falls into any of those categories, then it would mean that one can go ahead and operate, and that would be of benefit to the patient. The surgery in vogue is the pars plana vitrectomy, and because it is an abnormal posterior vitreous attachment, hence PVD induction becomes the extremely important step in this surgery. One should attempt what I call as foveal isolation, for a want of a better phrase, during surgery, and I will demonstrate it through a couple of surgical videos. An epiretinal membrane, if present along with the VMT, it's always nice to just remove it off. ILM peeling, when you remove the epiretinal membrane, well, you have two schools of thought. There is one school which says the residual ILM is a scaffold for reproliferation, so you better remove it. There is another school which would leave it alone. So I would say that if you end up creating a macular hole while attempting to operate a case of VMT, then ILM peeling would be mandatory. If not, then to each their own. And as we'll see in videos ahead, IOCT, if you have, it's an expensive toy, but if you have, it really helps in some crucial decision making in these cases and makes your life a little easier during surgery. Addendums to a good surgery in VMT, I am a strong believer, is triamcinolone staining, so that you can very clearly delineate the posterior hyaloid, and using a flat contact lens instead of a biome. With a reduction of one interface, a flat contact lens is going to give you much better clarity, better visualization of these delicate structures when you work close to the fovea. And IOCT, like I said, it's not a compulsion, but if you have it, your pockets are deep, then well and good. So let us see a couple of cases where we apply these concepts. Now, this was a case of proliferative diabetic retinopathy, had PDR, and at the fovea, you can see a vitreomacular traction with the adherent thickened hyaloid and a chronic pull on the fovea, creating one large coalesced cyst with a very thin roof. So I hope the video is playing. If you can see, after having done the core vitrectomy and have approached the posterior hyaloid, you can see with the cutter, I'm nibbling around the fovea. You can see the fovea as the xanthophilic pigmented area. So the aim is not to pull this hyaloid across the fovea so that you do not risk de-roofing. Slowly and surely go all around. And once you do that, you have basically separated or isolated the fovea from the rest of the hyaloid. And then the rest of the surgery can continue. If it's a clean VMT, it's just vitrectomy. If it's a diabetic surgery, then you go ahead and do your diabetic steps. So it's the same patient 1 month down the line, and I think 3-4 months down the line. As you can see, slowly the cyst goes back in position. Now, this was a VMT which caused a macular hole. If you can see, it's a full thickness hole, but it's a micro hole. It's a very small hole, which you can see in one of the axes, whereas in the other axis, it seems as if the hole is closed. Now, here we will see how a flat lens will give you a better visualization. I'm also using the IOCT to confirm the findings that were there pre-op. And we join the surgery from a point where the posterior hyaloid has been stained. So now this is a view under a flat lens. As you can see, this same step of nibbling can be done in greater magnification and with greater clarity. So you're much more confident moving your instrument around the fovea. Slowly and surely, you can very comfortably remove the hyaloid from around the fovea. And once the fovea gets isolated, you can go ahead and remove the posterior hyaloid conventionally using a suction at the disc, as you would do in any other PVD induction. So because you have separated out the fovea, there is no fear of the fovea now getting de-roofed. Again, you can see the hole very well closes post-op. Another view, herein I'm using a needle to incise the hyaloid. Sometimes the hyaloid is too thick to get captured into your cutter. A needle works very well. You create a plane and then insinuate your cutter inside the plane that you have created. And the same steps repeat. You go all around, isolate the fovea so that you do not end up deroofing. A small stub of the posterior cortical vitreous or the posterior hyaloid, which is attached immediately directly on the fovea, can actually be left behind, and in my experience, it just absorbs off in the post-operative phase. If you have a vitreomacular traction with the epiretinal membrane, so in these situations, how would you want to approach? So you can see very clearly vitreomacular traction, and you can see multiple planes of reflectivity on the retina, which indicate the presence of epiretinal membrane. This patient also had a cataract, so I remove the cataract, go in with the conventional steps. After having done a good core vitrectomy and staining the posterior hyaloid, I use the IOCT to ensure that I am entering the correct plane. Here again, I'm using a needle to incise the posterior hyaloid and reach the surface of the retina. Once the surface is reached, insinuating the cutter is not very difficult. And the same step of foveal isolation, that means all around, is done. Once that is done, the residual posterior hyaloid is raised off the disc and the pars plana vitrectomy is thus completed. As you can see, the puckering on the surface of the retina is now very clearly seen as an epiretinal membrane, but you no longer see the VMT on the IOCT. So this ERM gets a patchy stain and I'm able to remove it completely. Now, once removed, I take the advantage of the IOCT and see whether I've created a hole. And as you can see, CME is visible, but there is no hole that got created. And in this situation, I have restained again to just confirm that I've reached the retina. You can see this bluish restaining, which indicates that the tissue next visible right up there is the ILM. Now, practice to practice variation, I do not necessarily peel the ILM. So for me, this becomes a last step. Or in practices where you obligatory peel of the ILM, you can now peel it off because it has been very well stained. A last case, one of the most difficult subsets of VMT is when VMT is associated with vitreoskisis. This often occurs when you have concurrent high myopia or a pathologic myopia. So this is one such patient who presented to us. As you see, in 2022, her vision was 20/40. She had VMT even then, but she was comfortable with her vision and she was able to pull through all her activities well. So that is why there was no intervention advised. And 2 years down the line, she came back to the clinic with a very clear progression. You can see the schisis, you can see the pull on the retina, and you can see the drop of vision. So we took this patient up for surgery. And as I went in, I used the IOCT, cross-check the preoperative findings, core vitrectomy, staining with triamcinolone. And when I attempted a PVD, I could, after a couple of attempts, actually raise a layer off. As you can see, I'm again using a flat lens to raise off the hyaloid. And it looks as if very well the posterior hyaloid is coming off. As you see, you can see the retina looking very clean behind. So at this point, I felt the surgery is largely over. I have largely separated things out. But in the area where the clearance was achieved, when I did the IOCT, I could see one more layer. So I go in, stain again, and yes, I see one more layer. I remove that again. After removing that, I repeat the IOCT. As you can see, I'm staining and restaining, and I still am seeing some layer attached to the retina. So I go back in again, keep scraping around, this time with a soft tip, restain with triamcinolone, and surely one more layer of the hyaloid comes off. Re-OCT shows still I'm seeing another layer. So this was a fourth attempt of triamcinolone injection. By this time, I was like sweating. I don't know when this surgery will end. And you already have 4 or 5 trainees looking at you in your OR, thinking as if you are really not good at this surgery. And finally, towards my fifth or sixth attempt, I did not see any specific layer on the IOCT. So I stained with BBG dye. This for me is a final confirmation that everything has come off, because if you get a very good BBG staining and whatever you peel next comes off like a roll of tissue, that indicates that you have reached the ILM. And then I injected gas and we closed the case. And this is how the patient was 1 month down the line. She did well, vision had improved, and luckily for me, everything else was fine. So in conclusion, vitreomacular traction can come in various shapes and sizes. Uh, Intervene only if there is a definitive vision loss and metamorphopsia. Removal of the posterior hyaloid is the crux step of surgery. Whenever you're operating, ensure that you have a close eye on preventing de-roofing and causing macular roll on table. Stable hands, good magnification, contact lens, and triamcinolone, I feel, are four things which are really going to take you far in this surgery. And if you have deep pockets, an IOCT does not hurt. Thank you so much for the patient listening. And this is one review that we have put together on vitreomacular traction. Anyone who's interested can scan, and this has very good information about this entire pathology. And I think the first author is logged in right now. If it's the same Mansi Ketkar. Thank you so much.
Thank you, sir, for the wonderful talk. It was quite enlightening. Any questions from the panel?
Hello, sir. Good evening.
Hi, good evening.
Cases you have shown. I just wanted to ask regarding some simple VMTs that keep on coming like as an incidental finding sometimes. So for such cases, do you feel like you should just first give an attempt of injecting and not going directly into the surgery, like if it's a focal VMT and it can get released on its own with an injection, or you'll still think of taking that case?
So like I said, for me, if there is a vitreomacular traction, important thing is the patient losing vision? Is the patient having metamorphopsia? And in my book, metamorphopsia above vision, because a 20/40 patient may still be comfortable. But if the patient has 20/20 vision but has metamorphopsia, then it is really much more disturbing. And in my experience, I've also felt that metamorphopsia is a complaint that gives you better dividends post-surgery. It resolves in a more satisfying manner for the patient than vision loss. So anyways, that is what I will look at. If there is an indication for surgery, I would rather operate, because end of the day, this is a physical disease. It is something which is physically pulling the macula. So the edema that you're seeing there is not really something which is occurring as a breakdown of any barrier there. So I don't think injection would have a direct role. Having said that,
if it's a focal VMT and it gets resolved, like even when we inject IVTA, not the CME per se, but if the focal VMT can just get released after giving an injection, can we do that? Is there
actually, that release is irrespective of what injection you use, because what basically has happened there is you have disturbed the vitreous cavity. You might as well just put in a plain needle and come out. So you have disturbed the vitreous cavity, which possibly has caused a posterior vitreous detachment, and that is how your VMT has resolved, right? So yes, this is mentioned. Even you have ochriplasmin that has been used. We also had a short pilot done years ago in LVPI. Results were equivocal, but the concept was very interesting. I think one of my colleagues thought of giving IV mannitol. Run IV mannitol fast, cause the vitreous to contract and dehydrate, and see if the VMT goes off. So yeah, I think some of these things may work, but surgery is more predictable. So once you feel as a surgeon that definitely there is an indication for surgery, you back yourself that you are not going to bungle up the case. You have good visualization. I think this is one surgery which is short, relatively simple, with stable hands, and gives good dividends.
Right. So, and sir, like in fovea limiting vitrectomies that you are doing. So in such cases, you won't be doing an ILM peel, I suppose.
Yeah, I do not do ILM peel as a default in VMTs. For me, ILM peel becomes necessary if I have unfortunately ended up causing a macular hole while attempting to do a VMT surgery. Otherwise, I do not remove.
And just one last question that you were showing that case where you need to do multiple staining and then finally achieve the removal. In every setup, we don't have an IOCT. So like, when do you know it's the end point?
Yeah, that's good. So I think it's a very good question. Two things I would look at. Even we did not have IOCT a few years ago. Once you have removed what you feel is the hyaloid, I think it is important to restain. Go in the max magnification that you can, and then maybe take your cutter on low suction or maybe even a soft tip needle and see whether you can engage those triamcinolone crystals in a very free manner. If you feel they are not freely moving, that means there might be something which is still there. And again, for me, when my mind says, okay, fine, everything is freely moving and I think there is nothing else left, my last step, even if I'm not peeling the ILM, is to stain, then hold and attempt one peel somewhere, just initiate a peel so that I cross check with myself that the tissue that I'm holding is the internal limiting membrane. So that tells you have removed everything above.
Great, sir. Thank you so much, sir.
Thank you.
May I comment on this part?
Oh,
I
please do,
think
please.
I completely agree with you on not using or peeling ILM in all those cases generally. But in my experience, at least, this is the case where I would peel ILM and I mean stain with the membrane blue just to make sure that I got the hyaloid. This is how I would just look at it from my side.
Right.
Dr. Dave, can I ask a question, please?
Hi, Saran. Yes.
Thank you for the wonderful videos and such a nice recap listening to you again. My doubt was that, I mean, obviously we try to isolate the fovea and do not deroof and cause a macular hole. But in these eyes, when a nitrogenic macular hole does occur, are the consequences a bit different from a normal idiopathic macular hole, or it's not that grave an consequence which can occur?
Unfortunately, I can't answer that question because fortunately, I have not had such occurrences other than n is equal to 1. But yeah, so the one where I did get a hole, I then proceeded with a reverse ILM peel and gas injection. I think that patient reached 2040 N8, something like that. But I don't know if so. So you see, that result is pretty much in sync with the range in which our macular hole outcomes are. But I don't know if they in general do worse or they do better. And I don't want to know.
Of course. Thank you.
I think if there are no more comments, Dr. Kushal, would you like to introduce the next speaker? Thank you,
Yes.
sir. Thank you, Vix.
So hello everyone. So it's my honor to invite our next speaker, Dr. Adil Al-Akili. So he is a leading vitreoretina surgeon based in Riyadh, Saudi Arabia. He is currently working as a retina consultant and medical director at Maghrabi Eye and Dental Center at Riyadh, and he is also one of the board members of the Saudi Retina Group. So we would like to invite Dr. Adil for his talk on complications of ILM peeling in proliferative sickle cell retinopathy. Dr. Adil, please.
Thank you, Dr. Kushal, for the kind introduction. I don't know if you are seeing my presentation.
Yes, visible, Dr. Adil.
Okay. So I think it's really timely that this talk is following Dr. Vivek's talk because it's basically talking about complications that can happen with peeling membranes or ILM over the macula. I just want to mention that these are my disclosures and none of them are related to the talk today. So I'm just going to talk briefly about sickle cell retinopathy because this is somewhat an overlooked conditions in terms of the surgical aspects of it. Because generally we deal with cases that present with a non-proliferative stages, and typically they would self-infarct and not cause a lot of complications. However, we know that there are some of those proliferative cases in which we might end up having severe visual loss caused by macular ischemia and vitreous hemorrhage, traction retin detachment, and in some instances, neovascular glaucoma can develop. And this case might be a little bit different. However, it is a surgical case that touches on these aspects. But the part I'm going to focus about more is the macular changes that actually happens with the disease itself that are independent of the stage of the proliferation. Because these eyes typically present with some changes that are recently described in OCT, in which they start by the presence of parafoveal thinning that's visible on OCT. With the severe ischemia that tends to happen, some changes also develop in terms of the thinning of the inner retinal contour, which might be associated with foveal splaying. Of course, with the severe ischemia, those cases also end up with enlarged foveal avascular zone. And I mean, there has been reports of paracentral acute middle maculopathy, which is that small infarct that happens in the retina that can be occasionally described with those patients. However, generally, those changes don't end up with a lot of effect on the vision itself. And that's why not many people would focus on them. Looking at the OCT finding in those in sickle cell retinopathy, you can see the temporal parafoveal thinning here that's described, and then with that you develop the foveal splaying that's shown in the right side OCT. The cases that I'm going to describe, and I think I need to just jump off to the other presentation, is a patient who is known to be to have sickle cell retinopathy. He's actually a 40-year-old of African descent, and he basically had a very similar condition in the right eye, in which he developed a vitreous hemorrhage followed by epiretinal membrane and underwent an uneventful vitrectomy with epiretinal membrane peeling. However, in the right eye, and this is what I want to focus on, he ended up developing another recurrence of the epiretinal membrane. And in the second surgery, I ended up going into that eye and peeling the ILM, which is something that will maybe be the cause of the case, the changes that I'm going to describe in the left eye. This is the left eye. And as he continued to follow up with me, he developed this epiretinal membrane with this vitreomacular traction. And basically, you can notice in this eye from the color optus is that the patient had underwent peripheral laser photocoagulation. This has been a practice that generally has been abandoned because of the many papers that came out of Professor Bird out of the Jamaican population, in which he described that those peripheral non-perfusion area end up auto-infarcting and not really needing to have laser. And the laser itself actually does not change the overall progression of the disease, and thus it might actually affect the patient by causing traction or even epiretinal membrane formation. So what I'm showing to you in this case is that this eye, the left eye, was a 20/20 vision. With those macular changes, the vision dropped significantly to 20/70. So I offered the patient surgery, and this was back in 2022 in September. And because of the history of the first eye, I decided in this surgery to perform a vitrectomy and peel the ILM at the same time. And you can see here that basically the patient ended up earlier with a very good vision. He was 20/30, and it looked that we're doing well in both eyes. However, 8 weeks after the surgery, he actually lived in, or he was on a vacation back in the UK. He comes from the UK, and he called me and said, suddenly my vision started to deteriorate. And a day later, he called me and he said, I think I lost my vision completely. So my thought was that he actually probably had some vitreous hemorrhage or an issue with the proliferation. But he was seen in the UK and he was told that he had a retinal detachment. So he flew immediately back to Riyadh, and I took him immediately to the surgery. And I'm going to show you here the surgery, how it went. And what was really shocking was that what you're going to see here is that the patient actually presented with a large macular hole, a very large macular hole. Of course, this kind of situation brings up a lot of doubts in terms of the way we actually practice. And I think one of the issues that tends to happen with those situations is that you start to think about how you approach the case. You will see here as we go into with the video that the patient, you can see that I ended up having to leave some peripheral vitreous, not doing a lot of shaving. This is because those kind of situation in which you have very aggressive laser in the periphery, and you're considering whether this is whether going and peeling all of the hyaloid at the periphery will actually help out in those cases, or maybe you just end up complicating things because you might end up having a peripheral break. I'm gonna try and play the video by itself without needing to play the presentation because I'm struggling a little bit. So what basically ended up happening is that the patient had a very large macular hole, retinal detachment, and basically we needed to deal with that macular hole after we actually peeled off we actually peeled off the basically the ILM in this stage. Of course, because this is actually a very large macular hole, I don't think a simple temporal flap would be helpful to close that hole, but we also need to deal with that detachment. So as we see the video moving on, you can see that I'm
Dr. Adil, sorry,
Yes.
we are not able to see the video.
It's still not playing right now?
No, it's not playing.
Okay, now it's playing. Is it playing now?
At least I can't see. Dr. Kushal?
Yes,
Okay,
no, not playing, Dr. Adil, yes.
not playing. I'm
We are
very
stuck
sorry.
at the slide of the Optos image and
Okay.
OCT.
Okay, probably I just end up sharing my. I'll just
Sir, may I help
share
you,
my
sir?
screen. I can just share my screen and I'm just gonna play from here.
Yeah, double click on first option.
Okay.
Yeah. Yeah.
Okay, I'm just gonna play from here. So back to the case. It's gonna start playing right away. You can see it right now.
Yeah. Now we can see you,
Okay.
Dr. Adil.
Okay. I think I was I didn't notice that I did not share the screen.
Oh, no.
So going back to this talking about trying to peel shave and peel the hyaloid from the periphery. Generally on those cases, because you do have aggressive laser in the periphery, you in the first surgery you're always struggling with peeling the hyaloid and contemplating leaving it because you might end up with the peripheral break. And then many times you just can get away with it. But in this case, because of the detachment, you have to go back and remove all of the peripheral hyaloid that's there and deal with the periphery. And this is what we've done. Of course, this was done by manually because basically all of the changes were happening way far in the periphery, and it can be very difficult to deal with those cases just with single manually. I'm using here the flow backflush function of the machine because it helps fasten the surgery, and basically as we move forward we go back to the same issue of dealing with the large macular hole that you can see here. And because this is a detached retina and you're trying to, I'm also appealing ILM just to make sure that I don't leave any scaffold for PVR. And as we do this, we end up with some breaks. But the struggle is always when you have a large macular hole is you want to flatten the retina, try to peel ILM with the flattened retina. And it can be very challenging to do that without using PFO. But using PFO also very tricky because you have that large macular hole in which you are worried that you end up basically having the PFO going under the retina. We were lucky enough in this case, under very low pressure and controlled way to really inject the PFO, flatten the retina, and start to remove all of the residual ILM. However, as you can see here, because the macular hole is very large, I thought because it seems like it's stretched, I'm just gonna try and basically milk it and just get it back to approximate. And hopefully with that, I will end up just having it closed. Unfortunately, because there's definitely some traction that cannot be released just by peeling the PVR or the ILM. In this case, I ended up deciding basically to get a graft from the periphery and basically use the autologous retinal implant technique described by Professor Tamer Mahmoud to basically go ahead and close that macular hole with the retinal tissue. Fortunately, we ended up successfully using that graft and closing the hole, and with that even flattening the retina. You can see here that I'm struggling with the eye because it's filled with PFO. I don't want to remove the PFO, so I'm just creating my flap under PFO because in the periphery, but struggling with that because the retina is directly over the RP and the choroid, and this can be a challenging task. Fortunately, I ended up being able to move that flap and closing the hole. And as we did that, I'm trying just to run quickly with the video, but I basically could close that hole and flatten the retina. So those kind of cases highlights the struggle of making that decision, the initial decision of whether we ILM peeling in epiretinal membrane is always a wise decision. And I think this is something that we discussed in the earlier presentation. Unfortunately, you're sometimes biased by the decision you're making from the first eye. And this is why I decided initially to basically peel the ILM from the first surgery. But it went back and haunted me, and I ended up needing to do a very big surgery that was unplanned. Just moving quickly from from the slide and just talking about macular holes after vitrectomy for ILM peeling. This is a case that can happen in up to 1.5 cases. It's believed that this is because of it could be just because of the PVR itself, or a condition that causes changes in the macula, like our condition. We mentioned our challenges, but at the end, I just want to conclude by mentioning that it's macular hole RRD is a relatively common situation happening after proliferative sickle cell retinopathy, and it's usually advisable to defer from doing laser for the non-perfused area. And always reconsider your routine ILM peeling in epiretinal membrane, and especially in this kind of case. It's always also important to plan surgically those cases as you perform. And with this, I conclude my talk, and thank you for the opportunity again, especially for everyone who's with us in the panel today.
Thank you, Dr. Adil. Extremely challenging case, but want to ask a couple of things regarding the case. So when we have a slit-like macular hole, it is usually related to traction, which is in the beyond the equator. So is like were you thinking of avoiding a retinectomy or relaxing retinectomy to release the traction, or you were only thinking about the inverted flap technique in this case? What was your thought process?
I'm just not quite. I didn't quite understand the point. You're asking about
No, were you
specifically for
trying
this
to,
case?
yeah, were you trying to avoid relaxing retinectomy because of the configuration of the macular hole was quite pointing towards the traction in the periphery? Were you trying to avoid and salvage the retina, or what was the thought process?
So yes, I completely. Yeah, you're right. And the point you mentioned. I'm always worried in those kind of situation of basically ending up having a large macular hole and a retinectomy, a large retinectomy, and then really cannot find my anchors to really return that retina to its place. So I think always thinking about basically flattening the retina and dealing with the macula at a later stage is very important. Specifically in this case, because I felt that the detachment is also caused by the macular hole, or probably most likely by the macular hole itself. So I needed to deal with this in the initial surgery. And basically, it had to be done this way. I didn't find any other way of doing it.
But is it always you end up avoiding ILM peeling, or would you like to do an foveal sparing ILM peeling in these kind of tractions, which is there?
Yes, of course. There's that high risk of developing macular hole after ILM peeling generally. So I would, if I'm peeling ILM for any other reason than macular hole, I would avoid peeling the fovea. I'll spare the fovea because I know that there is always a risk, especially if I have an RD that the retina is thinned, and I might end up eventually, flattening the retina, not having a lot of PVR, but a macular hole later on down the line.
That is another aspect is using a short-term tamponade of PFCL in these kind of cases, and then come back to with silicone oil exchange, because it is laborious to even do an silicone oil exchange. Very good. Like, what are your thoughts on that technique?
Of course, I mean, it's using PFO generally in RDs, not just for macular hole, like Professor Tamer Mahmoud mentioned, is something that's a trend that's growing, and I think generally, if I struggle with flattening the retina, I would always defer to using PFO as a temporary tamponade and basically, live to fight another day.
It was a great case, challenging case. Vivek sir, I have one doubt connected to your talk as well. So there is a paper by Caprosi et al. Which actually measured the displacement angle when they used PFCL. So they measured an ideal angle of 165. When you put PFCL, basically it reduces the risk of having a macular hole or any iatrogenic trauma to the macula. What are your thoughts on that technique, especially where you told you avoid doing ILM peeling in your cases? Because ILM, when you're removing, it rips off the foot plates of Muller cells, which you don't want to do. That is the thought process. I believe that you don't want to remove the ILM. What are your thoughts on that technique of using a PFCL for ILM peeling?
I think this is in relation to retinal detachment, right? Or
No.
are we talking in terms of VMT?
In ILM peeling in ARM or VMT?
Right. I personally do not use PFCL much. I use the disc as a counter traction, right? But if you say, I feel that PFCL must be having an advantage because it's sort of holds the detached retina back. So you are able to peel much more comfortably. I am personally not aware of the paper. I have not read it. So have they talked of the angle in terms of decision-making point?
No, sir. The angle is between when you place the PFCL and when you lift the ILM. So the angle is more obtuse. It is less traumatic to the retinal surface. So that is what I'll share with the paper with you.
Okay.
Since you have done a lot of work on vitreomacular retraction, I thought I'll just take your thoughts on it.
Yeah, sure. But I don't think I have clarity about that. I would love to read the paper. If you can send
Sure,
it
sir.
across.
I'll,
Sure.
I'll just send it across. Any other thoughts, Dr. Kushal, Dr. Shraddha, Dr. Saveen, you have any thoughts on this?
No, not from my side.
I think we had wonderful talks from all the faculty. And I think if we are extremely thankful to Pan Ophthalmologica and all the panelists and all the speakers mentioned who participated in this session. And without wasting any more time, I would like to thank everyone and call on the next set of speakers. Thank you, everyone. Thank you so much.
Thank you.
Thank you. Thank you. Bye-bye.
Bye-bye.
Bye.
Thank you, everyone.
Thank you, speakers, for a great session. We'll quickly move on to our next session on breaking boundaries by going unconventional in vitreoretinal surgery. I would like to welcome all the esteemed speakers and panelists of this session to the unique webinar. I'll quickly introduce our first speaker. Let me have the honor of introducing Dr. Evangelos Manusakis from Greece. Dr. Evangelos has served in the Air Force Combat Wings and has held several positions, including head of the Health Services for 6 years. He was also the head of department at Hellenic Air Force Aeromedical Center in Greece for 18 years, from where he retired as Brigadier General. Since 2004, he is in charge of the retinal department at General Hospital Athens and is also currently practicing in his own private center at Athens, Greece. He's actively involved in ophthalmology residence education besides doing clinical work. And apart from vitreoretinal surgery, which of course is his main field of interest, he also carries out procedures covering a wide range of other eye surgeries. I would now like to invite Dr. Evangelos for presenting his talk on submacular hemorrhage, minimal vitrectomy, and alternate approach. Over to you, sir.
Hello, everybody. It's a great pleasure to be in this wonderful meeting, and I would like to thank the committee for the honor for inviting me to speak to your Congress. So, do you see? Okay. Okay, do you see my presentation?
Yes, sir. Yes, sir. We can see.
Okay. Sorry for that. Okay. Today, I'm going to talk about the submacular hemorrhage and minimal vitrectomy as an alternative approach. Before going to present my technique, I would like to briefly tell something about submacular hemorrhage. Submacular hemorrhage is blood accumulation under the macula between the RPE and the photoreceptors, and we all know that without treatment, it leads to irreversible photoreceptor damage. But if we displace it within 14 days, we may have satisfactory vision restoration. The causes of this disease mainly is choroidal neovascularization of any cause, like neovascular AMD, polypoidal, or other types of neovascularization. Of course, there are other more not so common causes like retinal macroaneurysm, rupture, trauma, and some coagulopathies. When we see this condition, it's important to distinguish if we have subretinal or sub-RPE hemorrhage, as subretinal hemorrhage is more damaging to the photoreceptors. So on the slit lamp, we shall see that the subretinal bleeding is more reddish compared to the sub-RP, which appears more dark. And also the yellow color indicates chronicity. OCT, of course, will help us to see if the blood is under the macula, under the retina, or under the RPE. For treatment reasons, it's important to classify this condition according to its extent. So we are talking according to the size. So we are talking for a small size when the submacular hemorrhage is less than 1 optic nerve head, medium size when it is less than 4 optic nerve heads diameter, large when it is outside the arcades up to the mid-periphery, and massive if it occupies more than 2 quartiles of the fundus. For documentation reasons, we usually take a color fundus, color photograph, where we can see the size, and also we can see the radius of the hemorrhage from the center of the fovea, which is a prognostic factor. If we don't know the reason, ICGA is much more better than fluorescence angiography, as it can penetrate the blood and the RPE. Of course, OCT is the most important, I think, examination, because with OCT we can see if the hemorrhage is subretinal or sub-RPE. We can estimate the thickness of the hemorrhage. We know that more than 400 microns thick carries a worse prognosis. We can see the reflectance of the submacular hemorrhage, which is an indirect measure of liquidity. And the lower the reflectance, the better the prognosis. And finally, we can see if we have an intact ellipsoid zone or external limiting membrane. Now, what are the treatment options? It depends on the size, the etiology, and the location. Simple non-CNV related bleeds can be simply monitored. If they are CNV related, we can use anti-VEGF as monotherapy. Pneumatic displacement, we can use it in larger hemorrhages, and vitrectomy and gas for even bigger hemorrhages. Or we can go with more aggressive approach like large retinectomy and CNV complex removal, which in general carries not very good prognosis. Intravitreal TPA, there's a question mark because TPA has been related with rebleeding, vitreous hemorrhage, and retinal toxicity. And some doctors reserve it for chronic cases or in cases with high reflectance. The classic way of dealing with this disease is vitrectomy and subretinal RTPA injection. So what we usually do, we do a core vitrectomy, then with a very flexible and fine needle, we inject RTPA under the retina. And once we have injected the RTPA, we make an exchange with air and then gas, and we ask the patient to keep supine for 1 hour and then to keep his face down for 3 to 5 days. An alternative method is the pneumatic displacement. Pneumatic displacement is something that is similar to what we do for pneumatic retinopathy for superior retinal detachment. How does it work? First of all, we take some aqueous humor from the anterior chamber, and then we inject pure gas and some adjuvants according to the surgeon preferences. Potential complications of pneumatic displacement is gas being injected subretinal or sub-RPE, acute hypertonia, which can lead to central retinal artery occlusion. That's why we need after the procedure to indirectly see the optic nerve to see if the vessels pulsate. And in phakic or small eyes, we can touch the lens or cornea endothelium when we take the aqueous from the anterior chamber. Now I'm going to present an alternative surgical approach for small or medium-sized submacular hemorrhage. This is a patient that came to our clinic, a 70-year-old man. He had AMD in both eyes. He reported visual acuity 0.3 before the incident. He was under anti-VEGF injection therapy, and on the fundoscopy we saw this hemorrhage. He was hyperop about 4 degrees, and his visual acuity was very, very low, 0.025. So what have I done in this case? In this case, instead of taking the aqueous humor from the anterior chamber, I performed a minimal anterior vitrectomy using the vitrector from the phaco machine. I put a trocar at 4 millimeters. I performed a minimal vitrectomy with, I told you, with the vitreous cutter from the phaco machine. And then from the same trocar, I inserted Avastin and then RTPA. After put these drugs, I touched the eye, and then from another side, I injected 0.3 ml of pure C3F8. After I put the gas, I touched the eye, and I felt that it was firm. So I put the vitrector inside again, and made some more vitrectomy. And I touched, I thought it was a little bit firm. I put third time inside, took out some vitreous, and then I felt that it was secure to take out the trocar, and the case has finished. So why did I do this approach? Because this was a one-eye phakic hyperopic patient with a very small eye. And I thought I would have difficult to remove at least 0.6 ml of aqueous humor from the anterior chamber. Also, I thought that I would have a big problems if I had uncontrolled postoperative hypertonia. And also, there would be a high risk of crystal lens injury or postoperative inflammation in the anterior chamber. This is the case before and after the procedure. The visual acuity increased, and we had a good anatomical result. So potential advantages of minimal vitrectomy compared to pneumatic displacement is that intraoperative and postoperative hypertonia is more controlled compared to pneumatic displacement, especially in eyes with pre-existing glaucoma, small hyperopic eyes, and of course, there is no risk of lens touch or endothelium like in the anterior, when we do anterior chamber paracentesis. And compared to 3 ppv, it's faster, less invasive procedure, much cheaper, and the vitreous is preserved, which is better if we are going to go on with anti-VEGF treatment in the future. In conclusion, although not an established technique, in small phakic or glaucomatous eyes, small and medium external-vascular etiology bleedings, apart from gas, anti-VEGF and TVA is planned to be injected, minimal anterior vitrectomy could offer some advantages compared to 3 pars-plana vitrectomy or pneumatic displacement. Thank you very much for your for being here with me today.
Thank you, Dr. Evangelos, for a very interesting presentation. I have just a few questions. One is, do you not do AC paracentesis at all when you do this minimal approach?
Of course I do. In this procedure, no, not at all.
You just do a minimal vitrectomy. That's how you control the IOP.
Just minimal vitrectomy. And the advantage is that you can go inside as many times as you like until you feel that the eye is soft enough to close and leave it.
So basically, you titrate the amount of vitrectomy needed with the by digitally seeing the pressure.
Yes, I digital press,
Sorry.
and I see if the eye is soft, and then I do 1, 2, or 3 times, and that's all.
And do you give any any glaucoma medication post your procedure routinely?
No.
Okay. And do you check the intraocular pressure a few hours after the procedure, like we usually do for pneumatic displacement?
No. After he goes out to the waiting room, and after 1 hour, I check him. I see how it is with the air tonometer. I don't touch it. A pulse air tonometer, and if it's okay, the patient goes. Sometimes you might give, let's say, a tablet of acetylozamide just for precaution reasons, but they don't usually need it, as you do in all cases when you put an expansive gas.
Okay. That was great. Yes, Dr. Mohammed has a question.
Yeah, thank you very much, Professor, for the nice presentation. And actually, I do have a similar approach, but the idea that if I'm going to take the patient to OR, that's mean I would rather do a complete vitrectomy and I do subretinal TPA. That's the purpose of taking the patient to OR. This is why I am adopting a much easier technique, which is done only outpatient. Because basically we are injecting the TPA, it's in the vitreous cavity. So why do you need to take the patient to OR to inject a TBA? So what I do, and I have a lot of cases done with this technique. So what I do basically, I inject the TBA and the anti-VEGF in the first day, and I keep the patient on supine position where the TBA will find its way close to the retina. Then I bring the patient next day, inject a bubble of SF6, and I keep the patient face down position. So this will allow the blood to be displaced away from the fovea. And I do have a lot of cases that were doing well with this procedure instead of taking the patient to OR, using or opening a vitrectomy back and doing only minimum vitrectomy. So what is have you came across, or tried to have a similar experience with just doing only an office-based technique?
No, haven't done. Usually, I did the pneumatic displacement, as I told you in the beginning. I put the gas, I put the anti-VEGF, and then I do paracentesis from the anterior chamber. But this eye was very small, really small eye, and 0.1 ml of anti-VEGF, 0.3 ml of C3F8, and 0.2 or 0.3 of I have already 0.6. So how am I going to evacuate 0.36 ml of volume from the eye? That's why I thought this. I don't use it as, let's say, regular. It's not a routine, but in very small eyes. And when you don't have you have a patient which they're not very mobile sometimes. You cannot bring him one day to do this and the second time the injection. But of course, your approach is very nice, and I will use it the next time. But it's an idea if somebody wants
And also,
to.
it's nice you bring it up because it has been shown that intravitreal TBA compared to subretinal TBA is almost as equal as both approach
Yes,
with
I totally agree. I totally agree with this.
exactly with minimum damage to RPE. It has been shown that subretinal TBA can cause RPE atrophy, can cause sometimes RPA rip, or even lead to more complication than if it's only intravitreal. And for sure, this is only in cases where it's medium to small sizes of subretinal blood.
To be honest with you, I also don't want to put TPA under the retina. If I'm going to put something, I will put it in the vitreous cavity. Finish.
It's safer.
Safer, much more safer.
Thank you, Prof. Thank you very much.
Thank you also.
Does any of the other speaker or panelists have any question or comments? Okay, if there are no comments, we'll move on to the next talk. Thank you, Dr. Angelos, for the amazing talk.
Thank you.
And
Thank you
I would
very
like to
much.
request Dr. Isha Acharya to introduce our next speaker. Over to you, Dr. Isha.
Thank you. So it's definitely, and I'll thank Pan Ophthalmologica to give me this opportunity. So I'd like to invite Dr. Honing Gustavo. He's a renowned vitreoretinal surgeon from Brazil, and he's the head of vitreoretinal microsurgery and medical retina department at the Honing Institute of Ophthalmology and Research. He has also been the vice president of HRPC, and has been a wet lab instructor at the ESCRS in Thessaloniki International Vitreoretinal Summer School. And he has presented and published widely, including the Retina Today and the WOC. So I'd like to invite Sir for his session on Excalibur, IOAB and Surprise. So IOAB and Surprise. So Sir, please speak.
Dr. Isha, thank you for the introduction. Good morning, good afternoon, or good evening, wherever you guys are. I would like to thank Arun and Vaibhav Sethi for the kind invitation. And I'm going to present you today a video which was awarded during the last American Society of Retina meeting. And I hope you enjoy it. After we finish it, it has a narration. We'll talk a little bit, okay? Thank you again for the kind invitation. Let me just share my screen here. Yes, let me see. Photos. Okay. Let me know if you can see my screen now. 1 second. Can you see it?
Not yet.
Let me see. And now?
No, sir.
Oops, let's do it again. Let me do it in a different fashion. Share. Screen. Screen broadcast. Let me see. I'm with my iPad, so just 1 second. Can you see it now?
No, not again.
Let me do it different, in a different way, sorry. Sorry for that. Share. Screen. Can you see now?
No, sir. I'm sorry. Yeah, we can't see.
It says it's recording. 1 second again. Share. Photos. Range. 1 second. Should be able to do it. Let me see the configurations here. Sorry for that.
Hello.
Yes.
Yeah, Doctor Sir, may I help you?
Of course, please.
Yeah, please click on share button. At the bottom side, a green color button. Then a window
Yeah.
will pop up. Then double click on first option, that is screen or desktop under the entire screen.
So I'm using an iPad, okay? So I put on share and then screen.
Then screen.
now-
Then click on casting.
On what?
Casting. Start casting.
Now I have start recording.
Yeah. Click on no start recording. Start casting.
I don't
Start
have that
casting, sir.
When you will click on screen now. So
I
what
don't
option what option you are seeing, sir?
So
let me talk with him in Portuguese. Okay.
And then screen. And then I have the option to start recording. It doesn't say start sharing.
Okay, then click on start recording.
Okay, screen, start recording. Okay, screen broadcasting.
Yeah, click on that.
Okay, done.
Then what is coming, sir?
Then it's sharing. Let me just see one thing here. Might be my failure. Sorry for that. Zoom.
I think that
might be
iPad, yeah, want permission. I think that.
Right. It has all the permissions. Zoom app.
Yeah, Zoom app.
Full access.
Yeah, allow all access you can give.
Can you see my screen now?
No.
So put the next one while we try to fix this. Sorry.
Yeah, I think so. We'll move on to the next speaker, and I would like request Dr. Prakhar Goyal to please introduce our next speaker. Meanwhile, Dr. Gastavu will figure out his Zoom platform.
Hi, good evening, everyone. Am I audible?
Yes, you are.
Yeah. So it is my great pleasure to introduce our next speaker, Dr. Muhammad Al-Hazazi. He's a well-known retina surgeon based in Riyadh, Saudi Arabia, Vice Dean at Al-Imam Muhammad Ibn Saud Islamic University. He is widely recognized for his expertise at the intersection of digital health, artificial intelligence, and innovations within ophthalmology. Dr. Al-Azazi has contributed significantly to national consensus guidelines for managing diabetic macular edema in Saudi Arabia as an expert panel member of the Saudi Retina Group, highlighting his prominence in ocular disease management and research. He is also an esteemed international speaker at major ophthalmology events, demonstrating his role in advancing pioneer innovations in the field. Today, Dr. Hazazi will be speaking on anterior chamber and pupil formation in pediatric traumatic rheumatogenic retinal detachment. Over to you, Dr. Hazazi.
Thank you very much. Thank you, Barakan. Thank you, the panel, for the nice introduction. Do you see my slides?
Yes, slides are visible.
So this is gonna be a short and quick presentation about cases that you may encounter on daily basis, and it has to be prepared with a quick reaction to these cases to come out with a good outcome. So as an introduction, what I'm going to talk is the occlusio pupillae is a common finding after pediatric trauma, especially retinal detachment. It can be a fibrous or it can be a fibrovascular membrane that form over the pupil, acting like a curtain. And this will prevent the surgeon from seeing anything beyond the lens posteriorly. And most of time it's chronic inflammation. So this is a case. She's a 7-year-old girl presenting with retinal detachment after a trauma by knife. The usual case was managed very well by treating the detachment and leaving the eye with silicone oil in place. So what happened that after around 6 weeks, the pupils start to constrict day by day, and you can see this is what the pupil look like. You are going to face a very aggressive membrane over the iris, and it's very crucial and important to have like a tooth forceps to start gripping. Sometimes you may fail to grip it at the first time. These membranes are very adherent to the underlying iris, and sometimes it's dangerous to keep just pulling without dissecting because it may pull the iris from its root and cause dehiscence. So it's advised to have like 2 kinds of forceps and make the sharing force between these 2 forceps, and try to dissect as much as you can until you reach the surface of the iris. Here I'm trying just to kind of grab the tissues from each other, trying to find any plane that I can go posteriorly. And you have to be patient with these cases. Are already an inflamed post-trauma, and you can expect everything in a trauma case. Viscoelastic materials are very important to tamponade the treatment in those cases, and also to give you better visualization. You can see I'm just injecting just to see what I'm going to do next. At this stage, now I'm trying to find a way to cut. If you see now, this is a sharp MVR. Once I just touched the membrane, because it was under tension, it immediately opened. And now I'm trying to kind of make multiple snips to relax this membrane, which is contracting posteriorly. The Coughlin hooks or any kind of manipulator is important to stretch the people from the center peripherally. And if you can notice, we are not dealing only with iris, we are dealing with an aggressive membrane adherent and going posteriorly to the iris. We looked inside, we found the retina still intact and flat. Now I'm trying to trim the iris along with the membrane underneath. It's not possible at all to separate the iris from this aggressive membrane. So by manual anterior chamber manipulation is mandatory for those cases. It cannot be done by one eye. Catheter can be used, but it will shed more of pigments and visualization will not be easy. The curved forceps are very helpful. Now I'm, passively removing the oil from the vitreous cavity. Then this is a second look to the retina and looks flat. It's severely, traumatized retina. Now I'm completing the job by, creating as much as big as I could do to create a big pupil. Because believe me, from the next day you will see the pupil, constricting again. And I noticed those cases are, you expect them to see after severe trauma with retinal detachment. Cases with adult ROP, I have maybe 5 cases with adult ROP, they exactly behave the same. And cases with a lot of manipulation and silicone oil. So what is important to keep in these cases, early intervention for those cases are very important. Pre-operative anti-VEGF may be mandatory if you see any kind of neovascularization. Intra-op, remove any scaffold like IOLs, lens capsule, or any fibrous membrane that you see. And if it is possible that you remove it from the first surgery, remove as much as you can to form a large pupil, and this will decrease the chance for the contraction. And if contraction happen, it's not only will cause like blockage for you to see the posterior part of the eye, it is also a problem that it will contract and cause ciliary body detachment and hypotony in future. And always use the bimanual approach. So in post-operative, you need to have the patient on very aggressive topical steroid, especially if you are using heavy silicone oil in pediatric, which usually accompanied by severe inflammation. And also a strong madretic if it will happen after the maybe this is important to use initially before we construct the pupil and somehow decrease the artificial. So this is the end of my presentation. Open for question. Thank you very much.
Thank you, Dr. Al-Ghazi, for that wonderful talk. I understand that pediatric retinal detachments, rheumatogenius retinal detachments itself are very difficult to counterweight, and then in associated with trauma, they becomes more difficult. And then when the AC is flat and you have such extensive pupillary membranes and 360-degree posterior synechiae, all that makes it very messy. So I just wanted to ask you one thing, that usually in ROP cases, like sometimes people do a complete, iridectomy, they remove the whole of the iris to have a better view of the fundus and for the better outcomes of the surgery. And then later sometimes they put an iris lens or something like that. So do you do that also, or what is your approach, that you do whatever maximum you can do a cut by this bimanual technique?
The case in ROP is different, where you have the retina is almost touching the iris, so you are left with almost limited choices. But the cases which is not, it's still in the gray zone, which is not black, not white, like those cases with retinal detachment, and you felt that you have done the job properly by end of the case, but then you discover that the patient is growing some membranes and start, to close the pupil maybe a week or two after the what you assume that it is a marvelous job from the beginning. So yeah, the ROP is a different story, but we are dealing with cases when you try to save the pupil for later on for those cases, then end up by finding the pupil is actually part has to be removed to save the eye and just to give the patient a functional vision after successful retina surgery.
Yes, and also there, like you mentioned, that these are usually chronic cases where there is growth of NVI, which has caused this extensive neurovascular lesion in the anterior chamber, causing it to collapse and form all these NVs. They can bleed very bad. So, do you inject these anti-VEGFs, Avastin, or anything in almost all of the cases, such cases, or depends on what your
No,
choice?
it's not the routine case where I inject anti-VEGF for all the cases. I just make it probably if there is a new vascularization that you can see. So this will make the case more difficult. And I may stress on one point, which is if you are dealing with especially adult ROP cases, I can admit that I lost few cases because I wanted to give the patient best visual outcome, but I discovered that I did actually a harmful job rather than saving the patient's vision because one patient in his like 25 or 30, he's one eye is somehow functional vision, the other eye he has a distorted pupil, and he's aphakic for almost 15 years. And I decided to go and formulate a pupil and put sclerofixated IOL. I did the job that I was proud of at the beginning. Then I discovered that after a very short period, probably 3 months, the patient started to grow a very aggressive membrane that I couldn't really deal with. Then I went back, I removed the the IOL. I remove all the remnant part that I can do, and I trimmed most of the iris. But again, the cyclitic membrane, which was dormant for a long time, I just like I took the pill. It was restricting continuously until he ended by physis bulbi. So those cases are very tricky. The approach, there is no special way to approach these cases, but I will say be aggressive if you are facing a problem like this, or the minimum that you can do, and leave the patient if he is quiet, because if it went sideways, there is no way back.
Dr. Guha has a comment to make.
Yeah, hi, fantastic presentation, Mohammed. How are you?
Good, everything is fine.
Wonderful presentation. Especially, I liked your bimanual technique, because to avoid traction on the cyclitic membrane and the ciliary body detachments and so forth, I really like the bimanual approach. But one comment I have to make: in these eyes, one have to be very careful. What I usually do is, in order to prevent migration of the oil again, because it's impossible sometimes to do inferior iridotomy in these cases, as you rightly described, because of the iridocapsular fusion, the cortical remnants, and so forth, as membranes that are forming behind the iris. So it's not easy to do an inferior iridotomy. So I usually combine a technique called retention sutures, which keeps the oil back, and the cornea, it doesn't affect the endothelium. Just a small comment. I usually combine with retention sutures. Wonderful technique again.
Thank you very much. No, this case is actually, it came to my attention as a referral from a different surgeon. I think, and I cannot accuse someone who did the case. Maybe perhaps he has done BI, but I cannot see it, you
No,
know.
they always close later on post-ops. Even multiple PIs, inferior iridotomy is close. So the comment I was trying to make is when one is doing a pupilloplasty, it's best to combine it with a something to retain the or keep the oil
Oh,
back.
yeah.
For example, retention.
Yeah, totally agree.
Also, sir, do you think that post-op in such pediatric cases, post-op or course of oral steroids and a subconj DEXA maybe could help prevent this post-op inflammation?
Yeah, totally agree. Yeah, those cases, I would always go with every single weapon you have. So at the end of the surgery, you may, leave some triamcinolone and AC, hit the eye with very frequent, steroid for the first, let's say, 10 days, every 1 hour. Trying to minimize the inflammation, because now we are not dealing with iris, which is reactive and can move. Now you are dealing with a membrane which is underlying the iris, and it's fused. And if you see me during the surgery, I'm dealing with maybe a paper-like iris, but a thick. It's a kind of elephant inside the eye. So it's really a tricky, and I'm sure those cases eventually they will go into more cyclitic membrane formation and contraction, and eventually cyclitic ciliary body detachment and hypotony. This is why at the end of the surgery, it's also important to make some SNPs. It's not going to prevent it 100%, but I'm sure if he is lucky, will decrease the chance of having the cyclitic, membrane formation and ciliary body detachment in future.
Right.
Thank you, Dr. Zazi.
Yeah.
Dr. Prakhar, you are muted.
Hello. Yeah, if there are no more questions, then we can move to the next talk. Thank you, Dr. Alazazi, for that wonderful talk.
Thank you,
I think we
everyone.
can ask Dr.
Yeah.
We can ask Dr. Gustavo if he's ready with this presentation.
I guess he should be ready.
We're kind of working on it. So we're working on it. I'm trying to get I'm trying to get his his transfer his presentation on my computer now. So I'm kind of working on it, but
Okay, then
do you
Dr.
want me to
Nimesh
do my
Patel.
presentation and then try to work on getting his downloaded?
Yeah, I think so. I think that will be good. You can do your presentation. So Dr. Nimesh Patel can, I think, introduce Dr. Alan Franklin.
Yeah, hello. Good evening, everyone. It's honored to introduce the next speaker, Dr. Alan Franklin from Alabama. He is a renowned vitreoretinal surgeon. He is associated with Mobile Information Medical Center, Alabama. He has been awarded with Senior Honor Award from prestigious ASRS in 2024. He is associated in clinical research for mainly for diabetic retinopathy, AMD, and 3D digitally assisted vitreoretinal surgery. He is also founder of Forward View of Pharma company, who is focused particularly for developing novel long-acting therapeutics in retinal diseases. Over to you, Dr. Franklin.
Well, thank you so much for the kind invitation. It's an honor to be in the program in general, and also working with great friends is it's an honor. So we talked about doing some kind of a little unconventional off the wall stuff. I'll first show a video and then show some AI sort of stuff that we're working on. This first video, this is a patient with a chronic vitreous hemorrhage. It's associated with a retinal vein occlusion. We get the vitreous hemorrhage up, and there's some residual kind of fibrotic neovascularization. We do intraoperative fluorescein angiography. And the fluorescein angiography really allows you to highlight the abnormal vessels. The contrast is great because it's white on black and it's a higher contrast. So now I figured we were already in there. Why don't we try to unblock the vein and do a sheathotomy? And so this particular instrument that I started out with um, was the shark skin forceps. They're a little serrated, so that helps. It got a little bit of a plane, but then I just went to a 27 gauge needle, and Dr. Al-Absadi has done these, and you just want to get the adhesion broken, and you can see we're just about there, and it's actually can be pretty tight. And so we're just breaking that adhesion in the one place, and once we feel like we've got the vein freed up, I think we're going to put some more fluorescein in and show that it's a bit more patent. And so we did that under fluorescein guidance. And there's a little bit of blood there, but you can see the vein that was sclerotic is now open. And I'll show a post-op picture showing that the vein that was pre-op as opposed to the reperfused post-op, and the vein appears post-operative reperfused, and patient had a good outcome, went from hand motions to 20/30. So that was just kind of another indication for fluorescein angiography, which worked nicely. So this is something I've been working on with Lu Yin, who's one of the vision scientists at Alcon. And we all talk about when we peel, do we get the internal limiting membrane or do we not? Sometimes it's hard to know with even if you have intraoperative OCT because the aperture on the OCT doesn't quite allow you to have the to have the resolution to tell if you've peeled the internal limiting membrane at this point. That might come, but we all know that after we have a successful peel, the retina will be a little more pale. And so what Lou and I did is we took still photographs of the retina before the peel and after the peel, and we compared a region of interest within that area before and after, and we looked at hue and saturation. And you can see this is a typical case. There's before on the right of the screen, and after it appears a little bit more pale. And so Lou measured the color intensity, hue, saturation before and after the peel. He uses it's a CIE color scheme, which is based on Photoshop. He digitizes the images and then analyzes them. And there's a difference in saturation on this patient. On this patient, you can see just without the numbers, you can see that there's a difference in what the retina appears to be. And again, we're seeing a difference qualitatively, but Lou can measure this quantitatively with the CIE color space. And we looked at about 8 patients. We really tried to control where the light pipe was, so that we didn't get an erroneous higher hue than others. And these are just representative cases before and after the peel. But if you look at these 8 patients, there is a little change in the hue, but the saturation on all of them, there was a significant change. So this is something where we're hoping that when we're doing epiretinal membrane and internal limiting membrane peels, you can take a still photograph before the peel then take another still photograph after the peel, then submit those images will then go into a second EPU or processor. And if there's a significant enough difference in the change of saturation, the monitor will tell you whether you had a successful internal limiting membrane peel based on the change of saturation or not. So I think this might be pretty helpful going down the road for us. We always say, did we peel it? Did we do another round of staining? And this is potentially a mechanism for us while we're waiting on the IOCT technology to come available to say, yes, you've peeled it, or no, you need to do more peeling. So that's kind of our where we are now.
Thank you, Dr. Allen, for your wonderful presentation. I would like to ask, like, how practical is the blue filter in Ingenuity that helps for ILM peeling to avoid the BBG dye?
I think it's pretty helpful. Really, I've not seen a bad peel with the or a bad stain with the blue enhancement. I almost always am able to see the stain with the new version of the Ingenuity. So it's really helped me out a bunch. I don't know what everybody else's
So are you avoiding BBG dye
experience
right now, or still using some cases or anything?
Am I still using? I'm sorry.
Sorry, are you still using BBG dye in particular cases, or you are just using the blue filter?
Oh, I'm using the BBG dye, and I use the blue filter on top of that. But I still use the BBG. I don't use that much, and I don't stain for that long, and there's no toxicity. So yeah, I still use it. And there was a case earlier with the multiple layers of cortical vitreous, and I've done that, and I'll sometimes put in the BBG, and I'll be able to peel the ILM, and once you peel the ILM, the vitreous comes off also. I've done that. But yeah, so I do use BBG a fair amount.
Thank you, Dr. Allen. Anyone from panel has a question or?
Hello, sir. Just a curious thing I wanted to ask. That interesting case that you showed in the beginning to reperfuse the vein. So I just wanted to ask what happens if there is a like reperfusion injury to a long-standing ischemic area when it is happening? Can it be possible?
That's a really good question. And I didn't mention this. But with the fluorescein, when we inject it, when we inject the fluorescein, we see the ischemic retina, and I laser fairly confluently in the ischemic retina. So that tends to help minimize the neovascular drive after the surgery.
Okay. Sure. Thank you, sir.
Thank you. If you can give me a moment, I'm having I'm trying to get Dr. Huning's lecture here.
Yes, Dr. Mohammed.
Yeah.
Yeah, meanwhile, Alan, thank you very much and nice to see you here again. Yeah, Mr. Mohammed. My question is there a best timing for for such approach if you have a patient who is a fresh, vein occlusion, or let's say you discover the patient in your clinic after a sheathing happened and maybe there is no perfusion. So what is the best timing for sheathotomy?
I think if you extrapolate from some of the clinical trials where with anti-VEGF versus Osherdex, there was a 6-month window, and the final best corrected visual acuity wasn't as good as the 3-month window with anti-VEGF. So I generally like to do these within 6 months of initial onset, but it can be difficult because you do some injections, they don't work, and maybe you add a steroid and it doesn't work. So usually around that 6-month time is when I'm looking to do it.
Thank you.
So guys, I'll try from my cell phone. Let's see if it works now. Sorry for the inconvenience. Let me share my screen.
I'm also downloading on my cell phone.
Yes, sir. Yeah, please do so.
Let me just find it here. Zoom. Okay.
Yeah, we can see your screen, sir.
Okay, perfect. Let me
Yeah,
just
minimize this and
open
open
it.
your presentation. Yeah. We
Yes,
can
I'll
see,
put
sir.
on the horizontal way. Do you have the audio?
Not yet.
No audio.
So I'll explain to you. So this was a case of a patient, okay, who had suffered a trauma with an intraocular metallic body, and it was sent to us like that, with just the sutures on at 9 o'clock. We decided to perform fake emulsification. We were not sure where the metallic body was because we didn't have at that time at that center ultrasound. Okay, so we could see there was a rupture in the posterior capsule. So we decided to go forward with the vitrectomy. And there was an intense hemovitreous, what led us to think we had the intraocular foreign body. And here we can see, while performing the posterior vitrectomy, we had corneal edema, but very gently we decided to do the vitrectomy. Remember, never to pull it, otherwise we're going to have a retinal rupture. And finally, putting before PFO, we grab it and slowly we bring it to the anterior chamber. It was a very complicated and difficult for anybody because it wasn't very squared. It has rounded borders. Okay, so we bring it again to the anterior chamber, and then slowly we will try to put it on the iris, open it to bring it out, and then go forward with a secondary IOL implantation. We put visco, OVD, but here is the thing, we cannot bring it out. And later I'm going to show you the reason we cannot perform it, okay? So I put it on the other side of the iris while I trying to stabilize the eye and then see what happened. My 20 gauge forceps is stuck in the sclerotomy. So the tip of it left the handpiece. So I leave it, and the first thing is, now the foreign body cannot fall again, otherwise I won't have the instrument to remove it. And then that's why the reason we call it Excalibur, you're gonna see it's almost impossible to take it out. The idea here was how to do it. Look at that. So we grab 2 needle holders and then pressing each time one very close to the other one to make sure it is closed the whole time and be able to remove it through this sclerotomy. Pay attention to this movement. So press it, hold it, Then you press it again. Remember, you must have a larger, a bigger needle holder. Otherwise, the ones we are used to use for eye surgery do not work properly. And here we have the comparison with King Arthur when he is removing the sword Excalibur from the rock. After we have performed the most difficult part of it, then we have the second difficult part, how to remove that foreign body without falling again. So we decide to expand our incision to more or less 6 millimeters, okay? And gently with a spatula, we still cannot remove it. Very gently, again, it's stuck. And I'm really, really careful with endothelium. Finally, we could do it. But pay attention, which was the reason. It has two tips, okay? And that one was behaving like a fish hook and wasn't allowing us to remove that. So look at how complex was the shape of this foreign body. So I finished the vitrectomy. We had a small lesion at the nasal part of the optic nerve because of the moment when it fell over the retina. And here, after a long surgery, I decided it was time to stop, to release any possible synechia, to suture this cornea, okay, and leave the secondary IOL implantation for 1 month later because we had some corneal edema. And that's, we have many young people. Look at what happened with the tip of the forceps. It's always good to know when you should stop. This is a month later, 4 weeks, okay? Then here we are going to proceed with a Yamane technique. In this case, we are using an MA60. I have no conflicts of interest. And we are using this IOL because it is the one disposable at the public system in Brazil. Available in the public system in Brazil. We don't have any PVDF haptics IOL in Brazil, so this makes the surgery a little bit more difficult. Here we are using a 30 gauge needle with thin walls, which helps us a lot to perform a better surgery. Then we cut it sometimes if it is a little bit bent. We do the cauterization, creating the flange, and then we suture it again because we had to open it. And finally, the last part of the surgery, we are going to perform an iridoplasty because we know how much this is important for these patients and for the improvement of the visual acuity. And here, my favorite technique is the Sipser knot. I pass it 4 times inside the loop. And then always remember, don't push too much, be gentle, and very, very slowly we pull it to check if the final result will be satisfactory. And here we can see something that we are okay with that. Finally, we do the irrigation, we suture all the incisions, remember that, to reduce the chances of endophthalmitis. And this is the patient a month after the second surgery. We can see the autofluorescence, where was the lesion when the foreign body fell again. That's it. Thank you so much for your kind attention. Let me just stop here. This is in honor of my father who passed away a year ago. Very well. Stop sharing. That's it.
Thank you very much, sir. It was quite an interesting case, and the analogy you showed is even more interesting to note. So, I just wanted to ask that
Dr. Isha, your voice is echoing.
just a second.
I muted Dr. Gustavo, sir.
Hello.
Yeah. Go ahead.
Now it's okay.
Yes.
So I wanted to ask, would you have used a scleral route in this case to take out the foreign body?
A what?
Would you have taken it through the scleral port itself by extending the sclerotomy?
So this could be an option. Usually, okay, I prefer doing it through the limbus because in my opinion, it reduces the chances of infection, okay? Always, the scleral sutures are a little bit complicated to deal. And my expectations were that it wouldn't be that difficult to remove because I didn't saw the second tip, which was like a fish hook, as I showed you in the middle. So this could be an option as well.
Okay, great. And sir, if at all the foreign body, the major portion of the foreign body lies outside the sclera, and if you see only some part of the intraocular foreign body, what's your approach in such cases?
Traumas are always such a discussion because we have some basic steps which we should follow, okay? But depends the size of the position of the incision, the size, the material. So I think there isn't a straight answer for that.
Great. And sir, other than this, what's the most unusual foreign body you have come across?
I think probably this was the one. And a few years ago, because we live here in an area where we have a lot of people living on the field, and usually April is the month of the wood traumas because they start to chop wood for the winter. Okay, so we have quite a museum here of for intraocular foreign bodies.
All right. Great, sir. It was a great talk. If any other panelist would like to ask anything.
I was just going to comment, this is a beautiful case, and it just shows that, yeah, as surgeons, we have to sometimes improvise and solve the problems in front of us. And you just have to have a clear head and solve the problem, which is exactly what Dr. Huning did. And he got out of trouble, marvelously. So kudos.
Thank you all, Alan. And I think this is the biggest tip we can have. Always a cold, a fresh mind. If you think you are not going okay, stop it. Give the eye a second chance. I think this is the main message here. Because this was a stressful surgery, okay? It took me like 1.5 hours after a long day. So stop and do the secondary IOL implantation, check it later. And as you could see, I didn't tell you, but the final visual acuity of this patient was 20/40. In this case, I was super satisfied with that. Anybody else?
I think Dr. Mohammed has.
Yeah, hi, Christopher. Nice presentation as usual. Nice to see you here again. Did you discover where is the entry site for that large foreign body?
So probably it was because this patient already came with that first suture, okay, that we were seeing at 9 o'clock. So probably, in my opinion, it entered almost parallel to the cornea, okay? It crossed the limbus, but I couldn't see any entrance in the anterior capsule. So probably it went under the iris and crossed the zonula on the other side. It was a very, very special trauma. First time I saw something like that, because when I was bringing the foreign body up, it fell because I had a posterior capsule which he didn't have any rupture. That was the reason of having it falling. Okay, so this is my theory in this case.
Nicely managed.
Thank you. Dr. Mohammed is talking. We have no microphone.
Okay. No, I was just saying, it was a nicely managed case.
Okay, thank you so much. Thank you so much.
Thank you.
So I think we can conclude this session. I would like to thank all the esteemed speakers and my fellow moderators for a great session. And thank you, Team Pan Ophthalmologica, for this one-of-a-kind webinar. And I think we would hand over the stage to the next session speakers and moderators. Thank you, everyone.
Thank you. Congratulations for the organization. Thanks. Bye-bye.
Hello, everyone. I hope I'm audible and we can start with the next session. I would like to welcome Dr. Rodrigo Jorge, who is a distinguished Brazilian vitreoretinal surgeon and he heads the Department of Ophthalmology at the University of Sao Paulo, which was also founded by him in the year 1998. He has mentored over more than 70 specialists, and his research and clinical expertise focus on retinal disorders, including diabetic retinopathy, macular diseases, ROP, and ocular oncology. He has more than 189 publications to his name. I welcome Dr. Rodrigo again. Could you share your screen, please?
Hello, do you hear me?
Yes, sir.
Okay, thank you very much, Vaibhav, and all the organization committee for inviting me for this wonderful virtual meeting. I'm going to talk about functional findings after finesse loop giant ILM flap for idiopathic macular holes. So I'm a speaker for Alcon, but I didn't receive any funding for this talk. And just to make a quick introduction, this is what we call the giant ILM flap that we do with the finesse loop. We start close to the inferior temporal arcade, and we progress, you start inferiorly, and we progress towards the center of the macular hole. So we started in the inferior part, and then we go temporal. And as we progress, we try to manipulate the ILM without touching the underlying retina that does not have the ILM anymore. And so this is the technique, and you're going to see that when we go inside again, we have a very large flap that has already around 4 to 5 by 3 millimeters. And this is a very important step. You have to aspirate, so the entire flap will cover the entire hole, entire macular hole. And sometimes the flap unfolds, and then you just go back and perform the traditional inverted ILM flap technique, as you can see here. It's very important. I'd like for you to pay attention. This case, we did it yesterday. I brought it for you today. So this is not a giant ILM flap. This is a flap that did not fold nicely as I wanted into the macular hole. So here you can see, I'm going to use a pointer here. So a laser pointer. Do you see the pointer?
Yeah.
Do you see the point? Okay. So here, at this part, I'd like this part to fold superiorly to cover the entire macular hole. So let me just. So you're going to see that I start the fluid air exchange, and it does not fold very nicely. So I go back to fluid, to BSS, and then I aspirate here, nasal superior. So then the flap folds very nicely. This step is very important. You must cover the entire macular hole with any flap. And so what we want the ceiling effect. I call it cork effect. You have to cover the entire macular hole so you can prevent postoperative hydration. If you don't have hydration, you have a scaffold for neuronal tissue growth underneath it. In the regular smaller flaps, like proposed by Michaleska, you have the bridge effect. The flap maintains the border close to each other. but it does not prevent hydration. So you may still have a recurrence because hydration may induce a reopening of the macular hole. So this is the advantage of a larger giant ILM flap. And I hope this results we're going to publish soon, and I hope it get accepted in International Journal of Retina and Vitreous and International Journal of Retina and Vitreous this year. So another technique that you may also use, another employment of the finesse loop ILM flap is for epiretinal membrane. Okay, so this is one of the first surgeries from my fellow Leonardo, and here you can see that he uses the finesse loop and he can completely remove the ILM and then also the epiretinal membrane, mainly using the finesse loop. So just to show that the technique and how you can easily remove with this in-block technique. So one of the reviewers, one of the criticism regarding this technique would be that the finesse loop would cause reduction in macular sensitivity. So we started to perform pre-op and post-op microperimetry in these patients. So this is a patient where we used the finesse loop to start the flap, and then we use it also the endograsped forceps to finish a traditional inverted ILM flap. And as you can see, there's a small improvement in the mean macular sensitivity in this case. And another one, another inverted flap, and as you can see, there is no reduction. I'm going to show you here with the laser pointer. You see here some reduction pre-operatively on the inferior left picture, but then after it, you have a better sensitivity in the central portion and also around the 4 degrees region. So again, this is the case of the giant flap that I just showed you. And again, you don't have a reduction in macular sensitivity. And we should be careful that we also have to show you some not very good results. As you can see here in this case, you can see this region here, there was a pinch with the end grasp forceps. And as you can see here, where you pinch the retina, and there is bleeding, you have a very reduced sensitivity. This patient cannot, the sensitivity in this point, this region here, I'm going to draw you because this is very important. So do you see it here? This is the post-op OCT. It's an epiretinal membrane. And here you have good sensibility before, and here after, where you pinch the retina with the end grasp forceps, you have a complete absence of sensitivity, no sensitivity at all. So with the finesse loop, it's very difficult to have this type of reduction in sensitivity. So this is a very preliminary result. And there was a significant increase actually in mean macular sensitivity threshold when you compare before and after surgery. And unfortunately, the best contour ellipse area, there's another parameter from microperimetry, is not a very good one, especially if these patients have underlying disease like age-related macular degeneration. The best contour ellipse area, it's going to be extremely variable. So, in conclusion, for these functional outcomes, there is no significant reduction observed in mean retinal sensitivity considering the central 6 degrees using the finesse loop. Actually, there was a significant increase in mean retinal sensitivity. And mean macular sensitivity thresholds appears to be a good parameter and better parameter to detect functional improvement compared to best contour ellipse area. And obviously, this we have important limitations. The analysis was restricted just to the central macula, and we have a low number of cases. And to finish, if you want to see more videos regarding this technique, you can go to Macular Tube channel or Retina News. Thank you very much, Vaibhav, and all the organizing committee for the opportunity to present in Pan Ophthalmologica.
Thank you, sir. I just have one question. Do you reserve this technique for larger macular holes or even for the smaller ones? Do you go for a conventional or prefer this technique?
A very, very good question. So we are just moving on with a prospective study comparing it for holes under 400 microns. So we are randomizing patients, and in one group we do the conventional technique that we remove the entire IOLM, like I showed in the in-block technique, but obviously it's for macular hole, there's no epiretinal membrane. And in the other group, we perform the giant IOLM flap. And this is a very good question. I don't have the answer yet, but the one important consideration is that if it's larger than 400 microns, then we go directly to the giant IOLM flap or the traditional inverted IOLM flap technique.
Thank you so much, sir. Anyone else have any questions?
So, hi, Rodrigo. This is Dr. Guha from Delhi. How are you? Wonderful
Hi.
presentation.
Great pleasure.
Yeah. So, I just wanted to clarify. You use the microperimetry to ascertain the macular function, which was a wonderful study you did. But did you also combine it with fundus autofluorescence just to see the comparison on the RP? Because we all know that microperimetry denotes the neurosensory retinal functions, the rods and photoreceptors, as you very well put it. But fundus autofluorescence gives a more idea of the RPE. So
this is,
would you like?
Yeah. This is a very good question also. I don't know if you paid attention, but the infrared, the reflectance of close to the infrared reflectance is also a very nice picture to check for the RPE. And as I showed in that case of the pinch, when you have a hypo infrared reflectance, you can check, the healthiness, how much did you damage the RPE. So we did not perform prospectively the blue autofluorescence, but by the infrared reflectance, you can estimate if you did some damage to the RPE or not.
So would you like to recommend this? As Manasi also asked, up to what diameter, size of the hole would you recommend this technique of giant ILM flaps?
We hear like we know that in our hands after 400 microns you have to start a failure of the conventional technique. So here in our service we perform flaps for macular holes with minimal linear diameter higher than 400 microns for all of them. Because if they recur, you're still going to have some ILM, like I showed you. There was one case that the flap unfolded and we had to reoperate, but then it closed. With this technique, with the second reoperation, we have 100% of closure in the pilot study that we are submitting for publication.
Of course, there would be an upper limit in very giant macular holes. Beyond
but
maybe
you know,
800.
the flap has, the flap has 3 millimeters. So it's a very, and why do you use the finesse loop? If you try to build this flap with the forceps, it will tear.
Yes.
So the finesse loop is wide. It has a wide, you can manipulate a larger portion of the ILM. If you go with a small 25 gauge forceps, you're going to tear the ILM. So you won't have a large flap.
Yeah, I usually do a superior flap and then it hinges down, and sometimes I don't even advise prone position, and it works well in my hands also. Yeah.
How do you perform the superior? Because with the finesse loop, the angle to perform it superiorly
No, I don't use the finesse loop much.
Okay.
Very fair.
Okay. Perfect.
Wonderful presentation.
Thank you. Shall I call up the next moderator?
Yes, we now on to our next presentation. So next, Dr. Mohammad Hassan from Egypt will be discussing and sharing his experience on macular hole from beginning till present. Sir, I request you to share your screen, please.
Yeah, okay. I'm just working on it. Yeah, everything is okay right now? Nice, okay.
Yes. Go ahead.
Okay. Hello, everybody. I'm really honored to be in this prestigious meeting among world-renowned vitreoretinal surgeons. And I'd really like to thank my dear friend Vibef and all the organizing committee for this great event. Really honored to be with you. Today I'm gonna discuss macular holes, and I'm gonna tell you the story from the beginning till now. As we all know, a primary macular hole is an idiopathic macular hole which is caused by vitreous traction, and also there is other possible causes of secondary macular holes of other pathologies. The previous theory of macular hole with the ILM, because ILM is highly cellular with a lot of fibroblasts, fibrocytes, so it acts as a scaffold for proliferation, causing a tangential traction around the fovea and thus causing the hole. Before going to surgery, I think all of us still rely on the whole form factor macular hole index. I know there is new parameters, but still it's of good prognostic value before surgeries. We depend on the type of the hole, the diameter, the edge of the hole, and duration of presentation, and the outer retinal biomarkers. And post-operatively, even we got some prognostic criteria from the pattern of healing. U is much more better than V and W. And I think it's very important to know the post-operative pattern of healing of macular hole. So basically, all of us know that we should remove all possible tissues for treatment of macular hole. And this is a very old and very ancient theory for treating a macular hole. Previously, they thought that just removing the ILM is enough to cure the hole. And so if we gonna start by the basic surgery for macular holes, this is a very old technique, and I think all of us passed through it. Just removing the ILM. I'm sorry for the bad quality of the video, it's a very old one. Just grasping the ILM with Eckert forceps and removing the ILM around the macula is enough to heal the hole. This is a very old and very classic theory, but it worked in some cases, but actually this is not the meanwhile work for us. This is another case. As we can see, I prefer to use the pinch and peel technique till now. I'm holding the ILM with an Eckert forceps. It's a special forceps with small tooth in its end, just enough for me to grasp the ILM. Just removing the ILM is enough to cure the hole. This is not accepted nowadays. So we shifted later on to the inverted ILM flaps, and as we can see here, just removal of the ILM, and instead of getting rid of it, we just flip it inside the hole. Previously, they thought that it's just a matter of stuffing the hole with ILM, and again, this is not true. It's not stuffing the hole with an ILM, it's just a scaffold to allow cellular proliferation and the healing of the hole with normal tissue. Some surgeons modified the technique of ILM flap to make it a hinged flap like this one, as we drag the ILM and we put it inside the hole, and we make a small hinge still attached to the edge of the ILM to allow better cellular proliferation. But nowadays, I think this is my preferred technique nowadays, is to use a temporal ILM flap. As we can see here, I start by grabbing a small snip from the ILM in the temporal area and just widen it longitudinally in both directions, up and down, and then just simply lifting the flap of ILM and flipping just over the hole. I don't need to manipulate the hole. It avoids a lot of trauma to the hole itself, and plus a very important advantage of this technique that I'm preserving the nasal part of the ILM, so I can use this part later on if the hole is not healed. I don't think the use of perfluorocarbon is of value in such cases, because when I just do my fluid air exchange, the surface tension of the air will flip the ILM to close the hole like this one. This is another case. As we can see, just starting in the temporal area and lifting the ILM up and down. After getting enough width, I just hold the ILM and elevating it to cover the macular hole. So gentle, with no manipulation to the hole itself. Yeah, just to cover the edge of the hole. I can widen the temporal part or leave it. It's okay. Just when I'm covering the hole by the ILM, it's enough for me. And after doing fluid air exchange, it's gonna flip and stuck to the hole, and that's it. Sometimes you may face some difficulties like this one. I was intending to go for this case by doing a routine temporal ILM flap, but let's see what's gonna happen. I'm trying to flip the flap, but see what I crossed the hole. Okay, and it was my bad, of course. I crossed the hole, so I decided in such a case to convert my case to an inverted ILM flap. I was afraid of incomplete closure or abnormal pattern of closure of the hole, so I completed my ILM and went back again to history by doing an inverted flap. I don't need to stuff the ILM, just covering the hole is enough for healing. Okay. Sometimes you may face some other complications like this one after staining of the ILM, after washing all the stain. And can you see when I peeled the ILM, when I stained the ILM, I found it was peeled before by another surgeon because it is a recurrent macular hole. So I decided to take or to lift a distant part of the ILM as a free graft, and then I stuffed it in the hole, and I think it's enough for healing. Of course, manipulations for such cases are better under PFCL. I don't know why I didn't use PFTL in this case, but it's okay, it worked. You can just turn off your infusion and stuff the hole with ILM, and it's okay. Of course, in large macular holes and resistant macular holes, you may need another tools, which is a transplant techniques. I don't have any experience in using the capsule technique or the amniotic membrane, but I sometimes use autologous retinal grafting. This is a very old surgery of mine, and this is not true. I just wanted to show you a great mistake of mine. I lifted the flap and just hanged it out in the mid-vitreous, so it slipped away. And of course, it was one of my early surgeries, so I don't think it's a successful one. But the most appropriate technique to use for autologous retinal grafting is to do a diathermy to the donor area, and then you have to cut the graft, injecting perfluorocarbon, and you have to slide the flap, I'm sorry, the graft, you have to slide it like this one under PFC to maintain its position. I mean, you have to put the flap in the hole in its correct position and not flipped upside down. And this is a very successful way for dealing with autologous retinal grafting. So as we noticed, there are a lot of techniques in managing macular holes, starting from the old macular access technique up to the temporal ILM flaps and retinal grafting for resistant cases. Again, I'm repeating my thanks and my appreciation to this great event, and hope to see you next year. Thank you so much.
Thank you, sir. That was an array of excellent surgical videos, and you demonstrated almost all techniques in this very short period of time.
Thank you so much. Thank you so much.
Sir, I would like to ask you, have you come across cases? Sir, have you come across cases which develop cystoid macular edema in the post-operative period?
Yeah, I faced some cases of post-operative cystoid macular edema, especially with the inverted ILM flaps. But most of these cases, they just went away within months. So I usually don't interfere for a post-operative cystoid macular edema. I have even a couple of cases, the edema disappeared in 6 months. I know it's a very long period, but it worth to wait for.
Thank you, sir. I would like to ask if any of the other panelists.
Yeah, so fantastic presentation, Mohammed.
Thank you, Dr. Wa.
Yeah, how are you?
I'm fine. How about you? Nice to meet you again.
Nice to meet you again.
Hope
Same
you're
here.
doing great. Hope you're doing great.
So, the question which was asked by the moderator right now. In chronic macular hole, sometimes in very large, there is, and with a cuff of fluid, which sometimes in chronic cases, large macular chronic, there is usually tenting, and there is a huge amount of cuff of fluid, which is very viscous. Sometimes the fluid, due to chronicity, becomes very viscous, and in those cases, they sometimes postoperatively you would find, as he wanted to suggest, that this is not a cystoid macular edema, but a SRF, subretinal fluid, persisting for a long. and which, as you rightly said, it absorbs. Given if the RP is healthy, it absorbs over a
Yeah,
long period of time.
yeah, I totally agree with you. Yeah. Any questions?
No, fantastic. No questions.
Well, thank you so much. Thank you. Nice to meet you again, Dr.
Thank
Buran.
you.
Okay. Can I go to my presentation?
Yeah, I have the privilege to introduce our very own Dr. Joyanta Shekhar Guha, distinguished retina specialist from Delhi. He is the founder of Sai Retina Foundation and has made advanced retinal care accessible to all. So, Dr. Guha, please go ahead with very large macular holes with amniotic membrane graft.
Yeah, screen share. Yes. Give me a second. Yeah. So is my screen visible to all, Himadri?
Yes.
Unmute.
Yes.
Thank you. So thank you very much, Vaibhav, the team, Arunadaya, Himadri, and everybody for having me on in a distinguished panel. So my topic is use of amniotic membrane graft in large refractory macular holes. So I'll be dealing in these restricted areas. Slide forward. Sorry for that. Yeah. So this, of course, is known to all. So Down gas, this classification, even without the OCT, and many of us, and many surgeons around the world follow this classification still now. But this was based on pathophysiology. Surgical prognosis cannot be made on the basis of this classification. So as we all know, the surgical goals are slowly changing, and macular hole closure. Can I have the window minimized here? So surgical goals are slowly changing, and macular hole is no longer the only target. Instead, the aim is also to re-establish out of foveal integrity, the external limiting membrane, and the ellipsoid zone continuity. And as I said, that there has been a paradigm shift in the strategies to tackle these holes. And a few years back, we found that less than 400 micron, they have a success rate of 100%, but holes more than 500 microns, they reach only 80% primary closure rates. So there was this Manchester macular hole study, which confirmed a worse outcome for full thickness macular hole beyond 650 micron. And these are the several parameters which have a bearing on the prognosis. I won't go into details, everybody knows. So, and these are the indices. I just want to highlight that besides the routine indices that were in vogue, the macular hole area indices has been a recent development where it accounts for tractional forces more comprehensive than the other indices and is considered a significant predictor of hole closure. Now, in these large holes beyond 650 or microns, what are the alternatives? As was discussed by the previous speakers, we can use autologous ILM flaps, perifoveal heterodissection, AMG graft, retinal transplantation. They are producing encouraging results for holes which are larger than 800 microns, especially with flat, dehydrated edges or recurrent or recalcitrant holes. So I would be focusing today on the large holes, chronic large flat dehydrated edges holes beyond 800 microns, and use of AMG graft that I've been using for the last several years. But this we know that amniotic graft comes into two types. One is cryopreserved and one lyophilized. and we use the cryopreserved because cryopreserved have the advantage of having biological factors more preserved, and which helps to enhance the neuroretinal regenerations. And the purpose is to enhance anatomical closure and improve visual outcomes. Mechanism, we all know, it acts as a scaffold, reduces inflammation, inhibits fibrosis, promotes regeneration. I'm going fast because of paucity of time. We are already very late, and I will not get my dinner because I'm speaking from. I spent 3 days in Amritsar, and the kitchen closes at 10. So techniques are there are two types: inlay graft, inlay, overlay, and technique that has been in vogue now since recently by Darius and his group, the triple S technique. They have better the staining the graft, precise sizing, and then by using a double punch and then positioning it. But I use my own technique, as I will show in my video, and I place it subretinally, not that's an inlay graft. Advantages are improved closure rate, and almost 100% closure rate. It has a potential for neurosensory retinal regeneration, and there is almost a 0% displacement in my case, in my hands. Complications, I have not seen any. Choroidal neovascularization. Of course, the follow-up period is still not very long, but anyway, till now there is no CNV, and it of course involves a special skill, and I'll show you my own technique. And ongoing research is evaluating the long-term efficacy and safety. And we have also, like Rodriguez, including, I will not show it today, but we are recently acquired in Amritsar the microperimeter, perimeter. So we'll and autofluorescence is being combined for long-term evaluation. So I'll just come out of the slides and show the video because there is a problem there. Yeah. So is the video visible to all? It's actually Himatri, the video
Yes,
is visible?
yes. Video is
Excellent.
visible.
Excellent. So of course, this is a assortment of cases. I start with this out of the topic, but I could edit it at the last moment. So I begin with optic nerve pit, use of the double layered, as I call it, AMG graft. So double patty technique, I sometimes name it. Just for interest sake, I'll soon come to the macular part of it. So anyway, so here, so I'll just pause it and I'll just talk about it. Here, just to protect, I'm using a brilliant blue stained Helon sodium halonate dye, which I injected under the hole. These are very large, more than 1,000 microns in diameter. And this I inject to, it acts theoretically. I have to prove it by the further studies, like I said, microperimetry and other things, that just like the Helon protects the endothelium. So my supposition is that the Helon would protect the RPE and enable because when I am sliding the amniotic membrane graft below the macula, below the hole underneath there, so there is this should serve as a protective shield. So here you saw that blue wave occurring. That's I call a blue wave, and I go in with two diamond dusted scrapers, old scrapers, not fresh ones. And here you would say I use a technique. If it is unstable, then it comes out. In this case, it was a very large hole. So when I released the scleral depression, it came out. You saw. Then I dragged it back, and in this case, this particular video I wanted to show you. I am using another layer of amniotic membrane graft, which I call the double patty technique. So another membrane graft I'm taking. Now it snugly fits. So my test is, and I would recommend it, that you do a scleral depression and release it suddenly. If it is unstable, it will come out of the hole by itself. You can see the post-obosity is snugly fitting. Now here's another case where I've used the amniotic membrane graft. There is a lot of artery atrophy. So amniotic membrane graft is being used by Tamer also in cases of myopic macular atrophy, where amniotic membrane is supposed to release nutritional factors, many growth factors, and have a good results. This is another case where after multiple surgeries elsewhere, they presented to me with a macular hole, and here, and I recently did the microperimetry study in this case. There are a lot of green points, and vision improved from hand movement to 6/24 in this atrophic macular hole after multiple surgeries. So, and this is the post-op result. And here, this is a very interesting. This is a subfoveal foreign body in which I removed the foreign body using a basket, you will see, and in doing so, I have created a macular hole. ILM was peeled earlier. That step I did not show. And here, then I'm removing the foreign body here. And then I place amniotic membrane graft in that. And lo and behold, from hand movement, the patient improved to 6/24. Some people have been advocating chorioretinotomy, as Sengul has also done, Sengul Ozdek. See, this is the post-op result, and this is the post-op pre and post. And the patient improved to 6/24. This is another case of myopic macular. I'm ending the video very soon, just a few more seconds. After this is very important. You have to do repeated staining, and is a vitreoskisis in these myopic cases. You have to remove the membranes and then place an amniotic membrane graft, because there is usually, as I said earlier, referring to Tamer's studies, he has recently started putting the amniotic membrane graft, and then he puts a ART, autologous retina transplant, on top. I just put a amniotic membrane graft in this case, and the patient improved. So here I'm ending the case with a video with a case of PVR. I stain under PFCL and then remove the ILM and put a membrane graft subretinally, and the patient improved. So thank you very much, guys. And
Wonderful couple of cases, Dr. Guha. I have just one question. Do you ever come across RP atrophy right at the center?
No. You mean after
the surgery? Yes.
No, as I said earlier, sometimes yes, I did encounter, depending, but RP atrophy right at the center, I have hardly come across, but just as a preventive thought, I started using the Heal-On technique. So I think studies would prove that RP is protected. I hope so. Let's see.
I'd like to call upon any other questions for Dr. Jayant.
Hi, Dr. Guha, Dr. Mandeep here.
Hi, Mandeep. How are you?
Very good, sir. A simple question. Whenever you look into the different articles that have been published for large macular holes outcomes, if you talk about visual acuity, there is a divide. Most of the articles say that you hardly get a visual acuity of 0.1 best, average. And then there are certain articles which also claim that you get close to 0.5, 0.4. What is your experience? What are the visual acuities generally you will end up with these bad cases?
Mandeep, wonderful question. Seeing is believing. So, and I want to appear cliched, but in our series and in our hands, as I've showed, it was a pleasant surprise that subfoveal, just one example, subfoveal foreign body, and previously, before the advent of AMG, graft or ART also, people used to go for these larger holes just on a simple premise. Rizzo and their group and other groups had shown earlier, and many other papers wrote that they just nowadays, of course, we are getting improvement in visual acuity. And if you have observed the OCTs, there is a neuroretinal regeneration from either side of those large holes, and which are encompassing the whole thing, and the ectopic synaptogenesis happening in ART cases in those large, and which is proven. Yeah. So I think that unless there is huge amount of those cases which have huge RPE atrophy, then there is no use operating those cases. But previously, before the advent of these techniques, there used to be even an improvement in scotoma. People used to go for macular surgeries just to have an improvement in scotoma. Now we are getting improvement in visual acuity as well, thanks to the methods. Thank you. Very good question.
So I wanted to ask, during PFCL air exchange, how do you prevent the displacement of AMG?
No, in my case, you must have observed that I just showed, if you had observed, that first of all, I place the graft subretin beneath the edges by using 2 DDMS. After I have created a space with the blue helon wave, and then I place the amniotic membrane subretinally, and still you can have a displacement. So then I use the sudden decompression technique. I showed you in one case, the hole was too large, the space was too large, a single AMG, even after placement of beneath the holes, I depress it and release the sclera, sudden decompression. And then that's a technique I learned by default. Now I am doing it in every case. If there is a tendency, the thing is not snugly fitting in, it will come out. And you can depress it maybe 1 or 2 times, and suddenly, and it will come out. That's my own default way of assessing whether it's snugly fitting or not. And in that case, I put 2 membranes, one on top of the other, calling it the double patty technique. So that's my technique, and I didn't have any displacement in any case.
Thank you, sir.
Maybe we can move on to the next speaker now. Dr. Sarang, please introduce Dr. Mandeep.
Thank you, Dr. Guha, for such a wonderful talk. And I would now like to introduce the last speaker for our session, Dr. Mandeep Lamba, who is a senior retina consultant from Dubai. He's head of the Prime LLC Vitreoretina Group, and he has extensive experience in vitreoretina as well as phaco-refractive surgeries. So he'll be speaking on intraoperative macular holes. So over to you, sir. Thank you so much.
Thank you. Good evening, everyone. Am I audible?
Yes, sir.
So good evening, everyone. Very nice to see a lot of new faces. I'm pretty disconnected with the ophthalmology scene in India and Delhi right now. Happened to meet Vaibhav for a very short duration. Somehow we clicked, and here I am presenting a couple of my cases. A very unusual topic, and I was told to present something which are experiences that happens in the OR. So that's what has been selected here. So as the topic indicates, intraoperative macular holes are something that have not been diagnosed in your preoperative examinations, and something that surgeon sees during the surgery on table. The challenges are you don't have OCTs available generally if you don't have intraocular OCTs in your OR. So you really don't know the anatomy of the hole, whether you're dealing with vitreoschisis, epiretinal membrane, and stuff like that. So generally, the holes can be classified etiologically as missed holes, something that a surgeon can miss in preoperative examination. Most common cause is accidental injuries. Most commonly, it happens because of the direct injury from an instrument to the macular area. It can happen while inducing a PVD or doing a membrane dissection, premacular membrane dissections. It can also happen because of sudden changes in the intraocular pressure, that is sudden compression and decompression. Sometimes if you lose your infusion and you're trying to reconnect it, your macula can split open. Or else it can be discoveries. Typically it happens because of spontaneous PVD in immediate preoperative period, more commonly seen in patients with who have received preparatory anti-VEGFs. So I'll move on to my first case, which is actually a patient with type 1 diabetes, 34-year-old young gentleman. This is his better eye. And this patient was obviously given an anti-VEGF. So whenever you're using, you're going close to macula and doing an epiretinal membrane dissection on top of the macula, it's always advisable to go ahead and use a bimanual technique. I mean, that's not a rocket science. Generally, also use a curved scissor or a blunt dissection with your cutter so that you are able to delaminate the membrane specifically at the macular area, because you don't want to have a retinal tear there. So this case was pretty well managed, and after I've dissected off the fibrovascular prolif completely, I did an ILM peeling. I restained the eye with triamcinolone looking for secondary membranes, and I was just trying to suck out the triamcinolone, and this is what happens. This is not a direct injury. The cutter is way up, far away from the macular area, but it was just quick burst of aspiration, and the vault of the macula actually gives away. Anyways, in response, I decided to go ahead and use the macular hole as a drainage hole, did a fluid exchange, and finally did a fluid air exchange, did laser and infused gas. So you can see when the subretinal fluid comes out, the hole looks pretty big. Anyway, so when this was happening, I had my fellow besides me, and his immediate response was that let's go ahead and do an ILM transplant. He has seen me doing in the past. So what are the options we have now? Do we extend the ILM peel? Do we use any kind of macular scaffold, or we just do nothing? Basically, I chose to do nothing. And that was because the macular hole, which actually appears to be much larger, while the viscous fluid subretinal fluid is coming out of it, when the fluid comes out, the debulking of the macular region happens, and the flaps actually fall onto itself, and the vicinity of the edges is pretty close. The hole would not be that bigger as it actually appears while the drainage is happening. So do a fluid exchange, then do a fluid air exchange, then assess the hole. Don't go by the hole that you've seen while the drainage was being done. So this actually remained a very small hole. So I did nothing for it. This is how patient was. The left side OCT shows immediate post-operative period. The right one is actually 3 months post-operative. It's doing well. My second case was again a young type 1 diabetic. So this lady has actually lost her other eye to multiple retinal surgeries, and she came to me with vitreous hemorrhage in the better eye. Well, this was more of an organized, acute on chronic kind of vitreous hemorrhage previously. And I gave her an option for surgery, but she was pretty scared because of what has happened with the other eye. She decided not to go for the surgery. Eventually, she presented with pain, and obviously it was neovascular glaucoma, not a florid NVI. It's basically angle involvement, but her pressures were pretty high, in high 40s. So now we injected anti-VEGF, and we decided to go ahead with surgery. A day before she came, and she reported that she is experiencing sudden drop in the vision, which I really didn't take seriously at that point of time. So what had happened is PVD had got induced, and now we are sitting with a macular hole, which is pretty medium to large macular hole. The challenge which this case actually posted was I was losing the cornea clarity pretty fast. So some of us who deal with these kind of patients would know it better that when you decompress the eye, which is at high 40s IOP, to your operating IOP, you tend to develop corneal endothelial folds. And that's what was going on with this eye. I was losing the view. Somehow I was able to finish the internal limiting membrane peeling, but I was not able to get fetch ILM to actually go ahead and stuff it in the hole. So I improvised. I decided to go ahead and stuff it with the fibrovascular bit. So this is a bit of fibrovascular proliferation that is stained, and that has been used as a scaffolding agent. In my opinion, this is never been documented. This has never been reported ever. This is a fundus photo and OCT of the same patient 4 months later after doing an oil removal and AGV implant. She is doing 20/70, doing pretty well. So to conclude, case 1, active suction can be a cause of intraocular macular hole, something we should be kept in mind. We should keep in mind and assess the hole once the hole is approximated to RP, not before when there is fluid in between. If drainage is sufficient, only ILM peeling is enough, and you really don't need to use any scaffold. Case 2, the stained fibrovascular proliferation bit can also be used as a scaffolding agent in addition to all the things which were shown, and Dr. Mohammed listed it pretty well. Thank you very much.
Thank you, sir, for a very interesting topic and those wonderful videos. A more common scenario that many of us have encountered is the presence of a macular hole in a rhegmatogenous retinal detachment where maybe a preoperative OCT was not done, or it's not a case of high myopia. So what is your preferred approach to deal with these kind of macular holes? Do you peel the ILM or would you just prefer to attach the retina and that sometimes closes the hole? What is your preferred practice pattern?
Well, see, macular holes in reg RDs and traction RDs are different scenarios altogether. I would peel the ILM in both of them. In reg RDs, I will not like to drain from the same macular hole. I don't mind creating a separate retinotomy, or but when it comes to traction retinal detachments, these holes generally tend to look much bigger. So, you can't create a different retinotomy altogether. You don't want to be using PFCL, and at the end of it, you reach a scenario where there is a bit of subretinal fluid, thick subretinal fluid persistent. And what are you going to do after that? You're going to stuff it with some, let's say, ILM or neurosensory graft, and that can actually get dislodged in the subretinal space as well. That challenge is not placed in reg RDs, where you can make the macula dry, you can do the ILM peel, and then probably decide if you really need a scaffold. So the video that I showed was basically only for traction retinal detachments, not for reg RDs.
Do any of the other panelists or the moderators have any questions or any comments?
Dr. Mandeep, you said you use gas in both the cases. Why the preference for gas and not oil?
No, I used gas in the first case. It was oil in the second case because she had NVG, and problems with NVG is you can really not predict. I didn't want to land up with vitreous hemorrhage again, diffuse vitreous hemorrhage. She's one-eyed as well. So that was oil. First case was gas because there was no other retinal tear. That was the only retinal break. We could secure very good laser. So I was pretty sure that gas would be good enough to support that retinal tear.
Okay, thanks.
If we don't have any more comments, then I think we can conclude this session. I would like to thank Team Pan Ophthalmologica and all the wonderful speakers for the participation and highlighting wonderful new techniques and giving information on other rare scenarios regarding macular holes. Thank you, everyone.
Thank you, everyone. Thanks.
Thank you. Thank you so much, all of you. Thank you. Great.